Yeah, I think I have the second. When you have.
It's all okay. Yeah? You are the host now.
The check, complete the panel of the genetic and molecular study, and then carry us to the a multivariate analysis. I think there's a
You speak in Turkish. Tell the guy, auditorium, that is
Auditorium kim var orada? Beni duyuyor musunuz?
is the host now.
Can I connect from here?
No, it's not your line.
I think my
Zoom.
suggestion is to
Duyuyoruz.
start with electric.
Hah, ben
Auditoriumdan
sen host sensin şu anda ona göre. David Lomanto kanalı açtı. Seni ev sahibi yaptı. Oturum sahibi yaptı. Kontrol eder
Tamam.
misin şu anda?
Ediyorum.
Efendim?
The journal is
Tamam mı?
similar. Yeah, it's so similar. We want to move.
Efendim Samet.
And
Günaydın.
project.
And you can plan a more deep study. with-
Vallahi nasıl kolay olacaksa orası için. Ben ikisinin aynı anda olmasını tercih ederim. İki odayı da yaptık çünkü ikisi de hazır. Odadan odaya geçeriz yani. Kazus Siliv'de olacak. Ruenvay revizyon yanında olacak. Ha, siz ayarlayın ekipleri. İkisini aynı anda başlatırız. Tamam, hadi bak.
Percentage of miss instability.
Duyuyor musun beni şey?
Or you look to the key 67 percentage of the.
Alo.
It's important.
Of the key
All of
RAS.
them very
Key RAS. But you don't have data. So if you have, you need to.
No, he said he's checking but still no answer.
No,
My suggestion,
it's already host.
your portfolio.
You're already the host.
Because when you have your portfolio allocations, you need to get plan. Super analysis and so on. But please start.
Ayşenur gel. Gel buraya. No, this is a pilot study. We agreed. We are talking about longitudinal prospective study which we will do.
Sesim geliyor mu size? Memur Bey.
Two of them.
Yes.
We
Emre,
Geliyor mu
Ayşenur
merhaba?
Hanım ameliyathaneyle konuşacağım şimdi.
Sesim geliyor mu?
Niyazi beni duyuyor musun?
Duyuyorum abi. Benim sesim geliyor mu?
Evet.
Tamam. Bir saniye bekleteceğim seni.
Evet.
Şu an tekrardan konuşur musun abi? Biraz kısa bakalım. Aynen. Sıfır
Ses
yaz.
deneme, ses kontrol. Niyazi beni duyuyor musun?
2-3 dakika yazarız. Emre abi. Emre abi sesin geliyor mu? Emre abi.
Bir
Emre abi.
saniye. Bir dakika. Niyazi bir saniye.
Hey hey hey hey. Burada ses.
I will join my computer now. Just a
Hey
minute.
hey hey.
Okay, and then we will say that both sides research need to travel to each other, and then they will do and they will see the application of the research
Okay, all okay.
and everything together. But bazen
Bizle konuşmuyorsunuz değil mi? Ben şu an anlaşılmıyor. Ses yapacağım. Tamam. Ben test yapıyorum. Niyazi beni duyuyor musun? Tamam, test yapıyorum. Niyazi beni duyuyor musun?
Efendim Emre abi. Efendim Emre abi.
Ha, duyuyorsun değil mi beni?
Duyuyorum, dışarıdaydık. Doktor bir şey
Tamam.
söyledi.
Yok şimdi Zoom'un içerisindeki David Hoca onlar
Abi
kendi
sesin senin çok kısıktan geliyor, derinden geliyor.
benim sesim sana derinden mi geliyor?
Evet, çok derinden geliyor sesin.
Bir dakika, yok bir saniye, sen çok açma.
İşte seni şu an ben çok fullledim. Öyle diyeyim ben sana.
Bu nasıl geliyor?
Abi biraz daha iyi de yine derinden geliyor.
Bir dakika, bir saniye.
Ne?
Ses deneme, ses kontrol. Ses 1 2 3
Biraz
1
daha
2 3
düzeliyor
1
da
2
yine
3
derinden geliyor. Böyle boğuk
1 2
geliyor.
3. Bir dakika dur. Açacağım. Ses deneme, ses kontrol. Ses 1 2 3 1 2 3. Ses deneme, ses kontrol. Şu an yüksek gönderiyorum. Emin misin?
Çok, evet, biraz kötü geliyor abi ses. Emir abi galiba.
Benim sesim mi kötü geliyor?
Abi senin sesin çok derinden geliyor. Acayip çok derinden geliyor. Dünkü gibi değil yani.
Oğlum ben hiçbir şeyle oynamadım ki
Biraz bağırarak konuşun.
ses deneme, ses kontrol.
Bir dakika. Taner abi sen şöyle içeri bilgisayara geçeyim. Bir dakika. Abi ben kendime dünkü ayarlar duruyor da tekrardan bir bakayım. Sen de bir bak.
Ya şöyle Zoom'un içerisinde ben çok yeşili çok üste
Abi
vuruyor
yok,
yani.
sesin nasıl biliyor musun? Hani kopuk kopuk geliyor. Çok derinden geliyor. Hani o tarafta bir şey varmış gibi duruyor. Dünkü ayarlar burada aynı şekilde duruyor. Sistemi açtığım gibiyim şu an. Şurada da var ya sağda. Hemen şurada siyah kapı. Hey hey hey hey. 1 2 3 4. 1 2 3 4 5 6 7 8 9 10. Hey hey. 5 5 hey hey. Ses deneme kontrol. 1 2 3 4 5. 1 2 3 4 5. 1 2 3 4 5. Hey hey. Hey hey. Hey hey. 1 2 3 hey hey. Hey hey. Hey hey. 1 2 3 4 5. Hey hey hey hey hey.
Ses deneme, ses kontrol geliyor mu?
Hey hey hey hey.
Niyazi beni duyuyor
Hey
musun?
hey. Abi düşük geliyor yine sesin.
Yok,
Düşük
ben
ve
oradan açıyorum.
bir daha konuş.
Niyazi,
Hey hey
Niyazi bir
hey
saniye.
hey hey. 1 2 3 4 5.
Niyazi
Bilgisayardan
beni duyuyor
yükleyebilirim
musun?
istersen abi.
Niyazi beni duyuyor musun? Niyazi
Duyuyorum, evet, duyuyorum.
beni duyuyor musun? Nasıl geliyor?
Yine aynı şekilde biraz daha kötüye gitti hatta.
Niyazi benim sesim
Efendim.
diğer taraftan da dinlesene, diğer tarafı bağlayıp.
Tamam, diğer taraftan dinliyorum. Diğer tarafa bağlıyorum. Bir dakika bekle.
Alo.
Hey.
Benim seni kabul edeyim. Benim bu ismi izlemesi benim şu an.
Ses deneme, ses kontrol.
Ayşe Hanım beni duyuyor musunuz? Ayşe Hanım beni duyuyor musunuz? Ayşe Hanım beni duyuyor musun? Abi bir dakika bir şey söyleyeyim. Bir takılı ikiye takılı. Bu Zoom'un katları. Yok, tamam. Zoom'un sesini sadece Zoom'a geri göndermiyor. Öyle gönderiyor. X2.
Ses yolluyorsun galiba. Bir saniye. Hey, hey, hey, hey. Sesin
Bir
geliyor mu
dakika.
Emre abi? Emre abi
Sen-
konuşur musun?
Ses deneme, ses kontrol, ses 1 2 3 1 2
Tamam,
3 1
burada düzeldi ama yine böyle bir eko var.
Nasıl yani Eko?
Yani böyle nasıl diyeyim, boğuk geliyor abi sesin. Ses şu
Benim
an
sesim geliyordur. Konuşsana bir dakika.
Niyazi abi beni duyabiliyor musun şu an? Ses deneme.
duyuyorum yine aynı şekilde. Bu sefer ses seviyesi yükseldi ama boğuk.
Boğuk ses. Tamam.
Al burası sende. Ümit'e devrediyorum buraya. Burada
Evet.
ses
Ses deneme, ses kontrol.
biraz daha
1, 2, 3, 4, 5.
tonlarsan daha iyi olur.
Ses deneme. Ses deneme 1, 2, 3. Hey.
Ya daha yüksek ama hani şöyle diyeyim, boğuk ses.
Hey.
Bir dakika. Bir daha konuşur musun abi? Sen bir konuş, ben buradan ayar etmeye çalışayım.
Ses
Emre abi
deneme.
bir konuş, biraz konuş.
Hey.
Emre abi
Ses
duyuyor
deneme 1,
musun
2,
beni?
3, 4, 5.
Ha, konuş böyle, ben buradan ayarlamaya çalışayım.
Ses deneme, ses kontrol, ses 1 2 3 1 2 3 ses
Evet,
deneme, ses
devam.
kontrol, ses 1 2 3 1 2 3 ses
Devam.
deneme, ses kontrol, ses 1 2 3 1 2 3 ses deneme, ses kontrol,
Biraz daha.
ses deneme, ses kontrol,
Ya ben
ses
biraz daha topladım da senin de oradan ufak bir yer yapman lazım.
ses deneme, ses kontrol, ses 1 2 3 1 2 3 ses deneme,
Tamam. Sen al bunu,
ses
ben geçeyim diğer
kontrol,
tarafa. Al. Evet,
ses deneme, ses kontrol,
gel.
Ses deneme 1, 2, 3, 4, 5.
Konuşuyorsun diye olabilir mi? Çünkü
olabilir,
normal.
olabilir. Ha? Ses deneme, ses kontrol.
Şu an daha iyi geliyor sesin ama
Niyazi.
şöyle bir salon var.
Efendim abi.
Niyazi biz şimdi dinliyoruz. Başka bir telefondan normal geliyor abi.
Tamam, ben diğer tarafa bakayım abi. Burası düzeldi bu arada. Diğer tarafa bakacağım şu
Hey.
an.
Ses deneme, ses kontrol 1, 2, 3. Abi.
Tamam, ben diğer tarafa geçiyorum. Burası tamam.
Abi
Böyle,
onu biliyorum ama senin zaten konuştuğunda da boğuk dedi ya.
Şu an neden yankı yapıyor?
Bizden
Benim-
yapıyor. Şu telefonun sesini
Benim sesim geliyor mu şu an?
Senin sesin geliyor. Ümit.
Temiz değil mi? Sıkıntı yok.
Devam et konuşmaya.
konuşmaya devam et diyor.
Konuşmaya
Temiz
devam et.
geliyor. Temiz geliyor değil mi sesim? Sesimde sıkıntı yok. Şimdi salonun etrafına da döneceğim. Bakayım.
Tamam,
Buralardan zıtı
ameliyathanenin
gelmiyor.
içinde-
Evet, ameliyathanın içinde geziyorum. Herhalde zırtı gelmiyor.
Yok, herhangi bir sıkıntı yok.
Bunu böyle çek.
Tamam, tamamdır.
Tamam. İki yakanızda çalışıyor mu?
Evet, 2'ye kadar çalışıyor bu salondaki. Niyazi diğerini ise 2'ye kadar çalışıyor.
Tamam. İkinci
Şimdi
yakayı
öbür salona geçiyor Niyazi. Oradan mı kontrol edecek sesinde parazit var mı yok mu, boğuk geliyor mu diye.
bu arada bak benim sesim biraz boğuk geliyor. Çünkü ben sesimde biraz hasta. Diğer arkadaşla konuşsun. Sen de konuş abi.
Tamam. Abi şu an ben
Şu an
konuşuyorum. Ses nasıl geliyor abi?
şu an daha iyi, güzel geliyor, ses net geliyor. Şimdi öbür
Bir de Nihat
salondan
abi
bir bak,
gelsin baksın. Tamamdır abi. Bekliyoruz biz.
oradan da ayarını yapsın.
Tamamdır abi.
Sesli
Niyazi
mi?
abi şimdi öbür salona geçsin. Orada bir kez daha dinle anlatı.
Abi sesim geliyor mu? Emre abi
Evet
diğer
abi. Şu an senin
salondayım.
sesin geliyor.
Niyazi bizim
Duyuyorum
sesimiz
seni abi. Duyuyorum.
geliyor mu?
Geliyor. Tamam.
Nasıl
Bunun
tartışacağız şu an?
hoparlörün arkasına yükselteceğim bunu. Bir
Tamam.
saniye.
Biz yükseltelim ama bizde gerçekten seviye yüksek yani. Ben şeyden bakıyorum. Ses kartındaki zoom'un üstündeki yeşil
Evet,
var ya
evet.
tanesi. O çok
Tamam.
yeşil üstünde
Bunun
vuruyor.
ses kartından yükseleceğim. Ses kartında bunda sıfırdaydım. Ama ses
Abi
kartı
monitör
yükselince de
sen
içeride şey
monitör
yapıyor. Çınlama yapıyor. Fazla
ha.
yükselmemem lazım. Beni
Abi
duydun mu?
konuşsana.
Ses nasıl abi peki?
Biraz ses yollar mısın bana?
Ses deneme, kontrol, ses bir 2 3. Biraz mikrofonu uzaktan konuşuyorum
Konuş,
hocam.
konuş.
Ses deneme, ses kontrol, ses bir 2 3.
Tamam,
Akın sen
bekle biraz abi. Bekle biraz. Ses içeride dönüyor.
Şu an ikinizin sesi de bana net geliyor.
Emre abi dur kulaklık
duyuyorsun,
takacağım.
değil mi?
Bir daha konuş.
Ses deneme, ses kontrol.
Tamam abi bekle. Bekle bir saniye.
Bir
Onu
tık bana
ayarlayacağım.
dipten
Hoparlör
geliyormuş gibi
kısmından
sesin.
kısık büyük ihtimal. Onu açacağım. Hoparlör kısmını açacağım. Hey, hey. Şu an geliyor mu?
Senin
Ses
sesin
deneme,
geliyor abi.
ses kontrol.
Yok yok sana demiyorum Emre abi. Hey. Can abi sesim geliyor mu? Geliyor mu? Geliyor.
Senin
Şu
sesin
an geliyor mu? Hey. Şu an geliyordur. Bir
sesin
saniye.
geliyor bana.
Hey, hey. Şu an geliyor mu?
Geliyor.
Şu an geliyor mu?
Geliyor
Karar
geliyor.
geliyor mu? Sesim salona geliyor mu? Şu an
Nasıl geliyorsa onun da öyle geliyor.
geliyor.
Onların mikrofonu kapalı galiba. Yo.
Ses kontrol. Ana master'dan kapatacağım o zaman. Hey, hey, hey, hey. Şu an
Geliyor
geliyor
geliyor.
mu abi? Bakar mısın? Gitti değil mi? Tamam. Emre abi sesim geliyor mu sana?
Geliyor.
Tamam. Bekle abi. Tamam. Emre abi konuşur musun bir?
Ses deneme, ses kontrol, ses bir 2 3. Uzaktan konuşuyorum
Tamam.
mikrofona.
Tamam.
Ses deneme, ses
Emre abi bir
kontrol.
saniye. Şu
Bak
maskeni
biz
takayım bir.
düşük böyle uzaktan olanları biz
Şu
yükseltiriz.
arkadan bağlar mısın abi sana zahmet?
Nasıl ses? Emre abinin sesi nasıl?
Bir, tık- bir daha konuşur musun?
Ben mi konuşayım?
Evet. Yo, öbürü biraz uzaktan geliyordu sesi. Mikrofona mı konuşuyor?
Evet evet abi az önce mikrofon harici bir yerden konuşuyorum.
Tamam tamam, o zaman uzaktan geldi ses, tamamdır.
Anıl'la konuşmamız lazım. Anıl'la konuş.
Bu arada biz farklı bir yerden dinliyoruz.
Abi kapıyı açsana zahmet.
Çok
Testlerini
güzel.
yapalım. Şu an sesim geliyor mu içeri? Geliyor. Tamam. Bu maske olduğu için. Hey hey hey hey hey hey hey. Şu an gitti mi? Gelmiyor değil mi?
Az bir dakika, bir daha test yapıp hemen haber vereceğim.
Emre abi.
Efendim.
Heh. Birden beşe
Niyazi,
kadar sayar mısın? Emre abi sesi
1,
geldi.
Niyazi
4,
oranın
5, 6, 7,
Geliyor
8,
mu
9,
Emre?
10.
Şu an geliyor. Konuş abi.
Deneme ses kontrol 1 2 3 1 2 3 ses
Tamam.
deneme ses kontrol 1 2 3
Peki, tamam
1
abi.
2 3
Ses bende sıkıntı yok. Geliyor sesin, net geliyor.
Tamam,
Ve
onu
şimdi
ayarlayacağım abi.
hastayı alacaklarmış galiba şimdi. Bana sordular alacağız diye.
İkisini aynı anda mı alıyorlar?
Bir dakika dur abi. Şuradan bir almam lazım seni. Tamam. Emre abi ses yollar mısın tekrardan?
Ses deneme ses kontrol. İki
Tamam,
salonda
Emre
beni
abi ses geliyor
temiz
değil mi?
duyuyor mu?
Tamam.
İki salonda beni temiz duyuyor mu?
Evet, temiz geliyor bana sesin.
Hey,
Niyazi sen beni
hey,
temiz duyuyor musun?
hey. Abi bir daha konuşur musun?
Ses deneme ses kontrol. Ses
Sesin
deneme
geliyor.
temiz mi?
Ben
Temiz mi?
ameliyat
Temiz.
masasından
Evet.
temiz geliyor.
Evet. Sesin
Tamam.
iyi abi. Şu an düzeldi sesin.
Tamam.
Onu da ayarlayacağım abi ben. Emre abi
Şöyle
sıkıntı yok.
sen de
Ben
sadece mikrofonla biraz ton verirsen kendi kulaklığından dinleyip
tamam.
şeyin Ümit'inkisi güzel geliyor ama seninkisi biraz böyle boğuk. Ama bu
Tamam. Şu
yani
an onu düzeltiyorum
orta
abi. Bir dakika
tonları
dur.
orta tonları biraz açık yani
Hey,
mid
hey,
tonları.
düzeltiyorum şu an abi.
Yoksa ama bir sıkıntı yok yani. Güzel anlaşılıyor her şey.
Şu an nasıl? Ses deneme kontrol. 1, 2, 3, 4,
Ses
5.
deneme, ses kontrol,
1, 2, 3,
ses
4,
deneme,
5. Şu an nasıl abi? 1, 2, 3, 4, 5. 1, 2,
konuş.
3, 4, 5. 1,
Güzel.
2, 3, 4, 5.
Yok.
Hey,
Ben
hey.
öyle gördüm.
Ses deneme kontrol. 1, 2, 3, 4, 5. Şu an nasıl sesim? Ses
Sürekli
deneme
konuşur
kontrol.
musun? Anlaşılmıyor.
1,
Yani
2, 3,
volüm
4, 5,
biraz
6,
düşük geliyor.
7, 8, 9, 10.
Aç
Hey, hey,
istersen kanka. Buraya da alacaklarmış çünkü.
hey, hey, hey, hey, hey, hey, hey. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Hey,
Yani
hey, hey,
tamam.
hey.
Volümün Niyazi beni duyuyor musun?
Duyuyorum abi.
Tamam. Demin önce volüm kıstın galiba da hani
Yok, şu an sesim seviyesi iyi değil mi?
şu an iyi.
Tamam.
Şu
Tonladım
an her
abi.
şey iyi abi. Şu an her
Tamam,
şey iyi.
tonladım abi. Tamam.
Tamam.
Bir
Şu an
saniye, tamam abi. Hey, hey, hey, hey. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5.
Niyazi biz senin sesi kapatalım mı?
Kapat, kapat abi, kapat. Benim sesi
Ben bir
kapat.
şey olursa beni ara ben açacağım. Şimdi hocalar gelecek ya
Tamam.
karşı tarafı
Diğer
kilitleyeyim.
Samos'tan hazır. Orada ameliyata
Ümit beni
başlayacaklar birazdan.
duyuyorsun değil mi?
Evet, duyuyorum.
Tamam. Niyazi sen de beni duyuyorsun.
Evet, duyuyorum.
Tamam.
Ses,
Niyazi bir konuşsana bir daha.
ses abi şu an çıkardım. Bekle, mikrofonu takayım.
Ha tamam çıkardın tamam. Sıkıntı yok tamam.
Tamam. Şu an konuşuyorum normal şekilde. 1, 2, 3, 4, 5. Ses deneme kontrol. Ses deneme kontrol. 1, 2, 3, 4, 5. Hey, hey.
Gösterdim bana.
1, 2, 3, 4,
Ümit
5.
sana nasıl geliyor bu?
Hey, hey.
Gayet net ve temiz geliyor Niyazi'nin sesi şu an.
Ha?
Bir de
Yok
maske falan
Net,
yeni çıkardım. Şu an
net ve
maske mi var
temiz geliyor
ağzında?
Niyazi.
kontrol. 1, 2, 3,
Tamam.
4, 5. Şu an iyi mi?
Konuş.
Hey, 1, 2, 3, 4, 5. Ses deneme kontrol.
Tamam iyi sıkıntı yok.
1,
Tamam.
2, 3, 4, 5. Tamam.
Tamam. Ya bana nereden geliyor bu şey?
Tamam mı Niyazi orası?
Hey, hey. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Hey, hey, hey, hey. Hey, hey, hey. Orası tamam. Orası sıkıntı yok. Tamam. 2 tane şey var. Şunu götür. Oraya bir tane de kablo case'inden de XLR çıkart. O şey şuradaydı sağda. Ben Ertan'a verdim onu nereden? Tamam, götür onu kendi salonuna. Sen başla, orada bir şey yok. Tak hocalara, devam. Hey, hey, hey, hey. Hey, hey. 1, 2, 3, 4, 5. Sound check. Hey hey. Hey hey. 1 2 3 4 5. 1 2 3 4 5. Alo. Kankam şu SI mikserde ben hoparlörü AUX'a bağladım. Tamam mı? Sesi nasıl bölebiliyorum? Zoom. Hey hey. 1 2 3 4 5. 1 2 3 4 5. Hey hey. Hey hey. Hey hey. Taner abi sana zahmet sesimi dinler misin içeriden ya abi? Aynen abi. Sesimi ben kapatacağım oradan onu bulmaya çalışıyorum. Şu an sesim geliyor mu? Hey hey. Hey hey hey hey. Şu an geliyor mu? Hey hey. Şu an geliyor. Hey hey. Bunu kapatınca ama şeyin de sesi gidiyor. Abi oraya bir şey koy da çöp kovasını koy da kapanmasın. Heh. Hey hey hey hey hey hey. 1 2 3 4 5. Hey. Hey hey. Hey hey. Hey hey. Hey hey. Evet evet burası hazır. Tamamdır getirsinler. Hey hey hey hey. Say. Hey. Hey hey hey hey hey hey. 1 2 3 4 5. 1 2 3 4 5 6 7 8 9 10. Hey hey 1 2 3 4 5 1 2 3 4 5 hey hey hey hey hey hey hey hey hey hey 1 2 3 4 5. Ben yukarıdayım ya. Hey hey 1 2 3 4 5 1 2 3 4 5 hey hey hey hey Sesim geliyor mu benim? Sesim geliyor mu? Sesim. Deneme bir, deneme 2, deneme 3. Deneme bir, deneme 2, deneme bir, deneme 2. Geliyor mu? Sesim geliyor mu? Deneme bir, deneme 2, deneme bir, deneme 2, deneme bir, deneme 2. Deneme bir, deneme 2. Şu an geliyor gösteriyor bak. Deneme bir, deneme 2, deneme bir, deneme 2, deneme bir, deneme bir, deneme bir, deneme. Aynen şu an geliyor. Deneme bir, deneme 2. Karşıya geliyor mu şu an sesim? Hangisinden?
Bak, bu maviler karşı oluyor, tamam mı?
Tamam Aksu.
Her kanalın
Bir şeyden bakalım sen geliyor
bundan.
musun?
Der ki 5. kanal bunu yükselt derse bardağı yükseltiyorsun.
Tamam
mı?
tamam.
Bu da grilerde bu salon için.
Tamam.
Şimdi kapattım. Hoca der ki ben kendisini duymak istiyorum derse.
Tamam anladım.
Bunu da hafiften açarsın ama açma. Demezler griller.
Tamam tamam.
Maviler
Onun şeyler ayarladık değil mi? Hangi ameliyathaneye bağlanacakları falan. Onu biz
tabii tabii bunu biz
güzel türlü açık bırakacağız.
tabii ben
Onlar buraya bağlanacak.
hepsini açtım. Karşı tarafa ses gidiyor. Atıyorum hoca der ki ben kendisini duymak istiyorum der. Benim sesim duyuyor.
Tamam bu açıkta. Konuşulabilir halde.
Ben sesimiz güzel değil mi hocam?
Evet şu an gider.
Kapatalım mı şu an?
Şuradan
Bunu biz bu
açmamız gerekiyor. Şu an açık. Bu kadar.
Tamam.
Oradan sıra tuttum ama. Bu hocam bu muydu?
Kaç yaşında hasta? Ben hastaya bir prezente edeyim de. 22 yaşında. Tamam. 18, 22. Livi var. Başka da ameliyatı yok. Arada mı yapılmış kolestektomi? Tamam.
40.1 kabinesi.
Okey.
Şu an burada değil mi?
Yo şimdi gelir. Ha, şimdi gelir. Saçı biraz seyrek olan.
Ve buraya da şey alalım sonra. Bunu almayı da tamam. Ben bacağı orada düşmedim hiç o şekilde getirmiştim. Bacağı sarı için. Yani. Evet, evet.
Sonda takacağız. Sonda lazım. Bu Mert kaça kadar düşmüştü kilosu? 140,
69'a kadar 140'tan 69'a
140, 69, şimdi 90.
Yok da.
140, 60, 70 diyeyim ben ona. 20 kilo geri kilo alım var ama mevcut vücut kitle indeksi 40. Tamam anlaştık.
Kulaklık var. Sen konuşayım dersen de. Ha. Evet, sen ameliyata fokus ol, ben konuşayım, tamam, öyle yapalım. Valla daha mantıklı. Hani he?
O kadar da şey değiliz ya. Profesyoneliz yani.
Tamam,
Bir kere performans yapma.
ben konuşayım.
Ekranı görüyor musun? Ekranı nerede?
Projenin verisi var ya. Bende Applied'in bir tane verisi var.
Hı hı.
Acayip güzel yani.
Güzel mi?
Çok önemli.
Applied da iyi marka da Türkiye'de çok önümüze gelmiyor ya. Çok güzel marka aslında. Amerikan markası.
Applied'in bir verisini keşfettim. Ondan aldım ben bayağı bir. 5 ile 6 ile gönderiyor ya.
He,
Tabii.
nasıl onun olayı ne? Daha mı lümen mi kalın?
Dümeni kalın muhtemelen. Ve çok da güzel yani. Ben bu zamana kadar gördüğüm en iyi veres oydu. Ben normalde yani sivilleri hiç takmıyorum da. Bypasslar.
Bu belli olmaz. Uzun süre bir. Yani.
Evet, evet. Sivilleri
Hı.
falan taktım. Ekranı birazcık daha ortaya alabilir miyiz? Ha, tamam, okey.
Tamam mı? Tamam, başlıyorum.
Manufur ayakkabıları servise yıkanayım hocam.
Tabii tabii.
Abi bana sana iyi gitti. Oraya boyamadı. Şimdi buradan çek diyeceğim. O kulağında mikrofon olursa olmaz.
Tamam, ben konuşurum, tamam. Bizim bu görüntümüz salonda mı şimdi?
Evet, Zoom görüntüsü geliyor şu an.
Ha?
Zoom görüntüsü.
Bizim Memorial 2 deneyimiz.
Ha, Memorial 1'de hazırlar şu anda. Burada örtmüşler. Kasamanın tarafı.
Onlar daha mı?
Onlar bir tık öndeler, evet evet.
Bu da şey,
Tamam.
orada yayına basılacak görüntü neyse onu gördük. Hocam isminiz neydi?
Samet. Tamam.
Şey, hani seslenecekler ya oradan Samet hocam size geçeceğiz falan diye biz anlayalım diye o yüzden.
Tamam.
Diğer tarafı yöneten hocam ismiyle.
Şöyle. Diğer tarafta Kasama var.
Hocam,
Doktor Kasama ve Celal.
sizin sesinizi kapatacağız.
Tamam, ama onu bana söyleyin ki ben boşa konuşmayayım yani.
Onlar muhtemelen diyecekler yani şey oraya geçiyoruz diyecekler.
Tamam. Tamam.
Maç şeyine gibi belki size bağlanımlı olacak. Biz Avrupa finali yarı final dedim. Bilmiyorum aynı anda olunca.
Aynı anda daha iyi aslında. Çünkü bu biraz uzun sürecek. Önce orada biraz oyalanacaklar, sonra buraya gelecekler gibi aslında. Yok yok hayır. Seyirciler olarak söylüyorum yani. Seyirciler hani mesela oraya... Ha? Yok o ameliyat kısa sürer. O sadece sleeve yapılacak. Bu sleeve to bypass yapılıyor. Hani o bundan daha kısa sürer normalde. Evet. Herhalde öbür tarafa bağlanmak isterler artık. Onu diyeyim de. Şuraya bağlanmak isterler artık diye düşünüyorum. Bunu görüyorlar mı?
Hepsini görüyorum.
Ha şu an görüyorlar burayı tamam.
Hangisi bir dakika? Hangisi kapalı?
Evet. Benimki
Sonra. Ha şu an mı? Test için. Tamam. Konuşuyorum şu an. Nasıl? Sesim geliyor mu? Tamam. Süper. Tamam. Hocayı duyuyor musunuz? Hocayı da deneyelim.
Can you hear me? Can you hear me? I'm Dr. Kasama speaking.
Şu an sesimiz geliyor mu?
Gelen kısmı var mı? Başka bir
Mutlu olmaması lazım hocam.
bir not yazıyor ama.
Pardon hocam. Şu an gidiyor olması lazım. Tamamdır.
şu anda sesim gidiyor mu?
Evet.
Salon beni duyuyor mu?
Gelmiyor.
Şu an sesimiz geliyor mu bizim?
Seninki geliyor.
Tamam sesim geliyor mu benim?
Merhaba, salon bizi duyuyor mu?
Sesimiz geliyor mu
Celal
şu an?
kolay gelsin.
Benim sesimi
Celal duyuyor
duyuyor
musun
mu?
sesimi?
Celal öbür tarafta mı? Sen oraya mı bağlandı? Bire mi bağlandı şu
Ha,
anda?
yanlış odaya bağlandınız. Sametciğim beni duyuyor musun?
Ha, ben duyuyorum. Duyuyorum Mahir abi.
Tamam. İki nolu oda henüz hazır değil. Biz bir nolu odaya bir bağlanalım arkadaşlar.
Biri ilk trokarı girdi. Oraya bağlandı.
Teknik birinci odaya bağlansın. Samet istersen bu arada sen sizin hastayla ilgili bir bilgi ver.
Evet. Yes, this patient is 22 years old, lady. She had a sleeve gastrectomy 4 years ago. Before sleeve gastrectomy, 140 kilograms, and she lose weight and became 70 kilograms. And after that, she had a cholecystectomy and she gained 20 kilograms more, and now 90 kilograms and the BMI 40. Current BMI 40. We are planning to perform sleeve to Roux-en-Y gastric bypass conversion. If the voice is has no problem, I'll
Yeah, we can hear you perfectly and clearly. And you are planning to do a Roux-en-Y gastric bypass as a
yes.
conversion of the previous sleeve gastrectomy. We don't call it as revision because you will change the concept of the procedure. Okay, the main reason is for the weight gain, or main reason is there any stricture or something?
No, there is
Which room
no
I'm
narrow
on?
point.
Yeah.
There is no symptoms. We investigated barium swallowgraphies, and there is no reflux, and there is no narrow point or mid-sleeve narrowness,
Stricture. Yeah. Okay.
mid-sleeve structure. We don't have.
Thank you, Samet. Can you also introduce the people inside the room? Ahmet Ziya Balta is there, I
Yes.
believe.
Professor Balta.
Hi,
the
Ahmet.
perform-
Kasama, that's right. Kasama.
Morning, everyone.
And okay, and the team, you know the team, assistant and the nurses.
Please introduce yourself, Dr. Matt. Dr. Matt.
Okay.
Dr. Matt, general surgeon specialist, will help you.
Perfect.
Will help us for surgery, and the nurse, please, Nurse Özlem.
Okay, then thank you. Then
The
while
patient
you
is
are
almost ready.
okay, while you are preparing your patient, we will just go back to room number 1, and we will see Kasama and Celal as they already inserted the trocars, and we'll get some information from them about the patient. Thank you. Bizi birinci odaya bağlar mısınız lütfen? Celal, bizi duyuyor musunuz?
Duyuyorum abi. Sesimiz
Okay.
geliyor mu?
Yes, we are now on, and we can see that you're inserting your trocars at the moment. Before you start, can you please give some information about the patient? On this side in the salon, we are actually moderating the session with Professor Turgut İpek and Professor Gianfranco Sleccia, and it will be interactive, and you can get some questions during the case. I know that it's going to be a quick case, but we will try to ask the questions, and I'll be grateful if you can explain the steps as you do, and please give some information about the patient in the meantime.
Yes, thank you very much for introducing. And we are happy to hold these operations here. And thank you for having us here to the organizing committee, and also you, Professor. And we today we are performing a sleeve gastrectomy to a patient, to a female patient who is 27 years old, and she has no previous surgery from abdomen, and we will planning to do standard sleeve gastrectomy for her. The operating surgeon is Professor Kasama, and the second assistant is Dr. Almir here with us, and nurses Ece and Sevda is here for us.
And the head up, please.
We have
Head up.
imputed the trocars with the abdominal cavity, and we are
Oh, yeah, go ahead.
going to retract the liver with the Nathanson
Mo.
retractor.
Yes, that's good. Thank you.
Kasama, hearing you now.
Thank you. So I try to put Nathan's on, and actually that I'm not quite familiar with Nathanson. I usually
Okay,
use...
just Kazu, I know that you're not familiar with the Nathanson. You can just let them to insert the trocar if you like, and yeah, you can do it now. Okay, Kazu, we are following your steps. After you finish,
It's the Nathanson if you want.
Okay.
in the meantime,
You can do the Nathanson. Yeah.
Pozisyon verelim hastaya, baş yukarı olsun. Evet.
arkadaşlar trocar Nathanson isterseniz siz yerleştirin. O ters gelmiş olabilir ona.
Tamam
Onlar
abi ben
farklı bir trokar kullanıyor. O yüzden uğraşmasın şeyle. Direkt
ben
işleme başlasın.
yerleştim. Tamam. Kaldır, devam.
Kazu, here we have Professor İpek and
Hı.
Professor Sleccia, and we all would like to say that good luck with the case, and as soon as you start, we will hear the steps from you. And in the meantime, we will go back to second room and we will come back to you in a couple of minutes. Okay?
Okay, good. Thank you.
Hadi şu masaya biraz baş yukarı, biraz bana doğru çevirir misiniz
Şu
arkadaşlar?
odaya bir gidelim mi arkadaşlar?
Yap
Soru
baş.
sormak isteyen
Baş.
direkt soru sorabilir.
Şimdi bana doğru.
Şeyi yerleştirsinler.
Tamam, teşekkür ederim.
İkinci odaya bir bağlan, diğer odaya.
Aşağıda biri var. Okey. Tamam. Açsanız abicim şeyi. Bu açayım ki girsinler. Böyle bilir
Sesi
mi?
kapatın yalnız çocuklar.
Tamam.
Bağlı duracaksak tamam.
Önce bunu kapat. Kapat abi. Olmadı. Beni oynattın. Açar mısın tekrar? Tamam. Aç. Ne aç?
Evet.
Şunu açar mısın? Evet, şimdi ya.
Ahmet girdiniz mi? Birinci odada mıyız, ikinci odada mıyız?
Excuse me, I have the microphone and I'll talk. Dr. Balta will perform the surgery and I'll
Okay.
explain.
Kapat.
Okay, Samet, we are on your side now, and
Yes.
are you inserting a
Now
trocar?
we are inserting the second trocar.
Mhm.
Inserted second trocar. This is a small adhesion. So we prefer to insert the other trocar first, the other side, right side.
Great. Thank you. Thank you. Yeah.
It is 12 millimeter trocar.
All
You
right.
can have some right-sided
So
too.
left side.
Can I have my grasper? Grasper, please. And the other grasper of this. Yeah. So would you put
O
Evet.
ses birinci
Or
odanın
gerçekten
sesi ama
müzik.
ikinci odanın sesiyle
Yerleştirelim
karışıyor.
arkadaşlar.
Bizi
Gönder
birinci
bunu.
odaya götürün o zaman. Geçelim şimdi lütfen.
Liga şuraya.
30'dayım hocam.
Devam et.
35.
Devam. Gönder.
It's coming? Yeah.
Gönder. Yes.
Yes.
Kazu, we are back. Kazu, we are back to you
Oh,
now.
thank you. Yeah. So
Yeah. Okay,
now
please. We can hear you. Please explain what you are doing for the audience here.
Okay, so this is three gastric patients, and now I just ask my anesthesiologist to push the bougie inside here, the bougie, 38 French bougie, and ask her to suction inside.
Aspire edelim. Bujiyi aspire edelim.
And pull back the bougie.
Good morning, Gianfranco Silecchia. What's the bougie size that you have in the stomach?
38 French bougie.
Sorry, what's the size?
38 French.
38.
38, right?
38.
Yeah. So pull back the bougie.
Yes. Devam et. Bujiyi ilerletelim.
Yeah, pull back. Until here. Pull. Yeah, really. Yes, yeah, this is the place. This is good. This place is good. So this is the bougie now, and I check this is the pyrite clean, right? This is the pyrite clean. Then this is the 3 centimeter. This is my grasper. I always bring my own grasper to the live surgery abroad. And this is the 3 centimeter. The 3 centimeter, I usually preserve the 4 centimeter. So 4 centimeter is around this area. Okay.
So you always do 3-4 centimeters, or you always adjust the size of the length of the distance from the pylorus based on the patient. For example, I do 2 centimeters for every patient. What is your selection? Yeah.
4 centimeter. 4.
Okay.
4.
And if this case was the first step of a SADIS, what's will be the distance from the pylorus? Then you will start the stapler.
No, using other stapler.
If the sleeve was the first step of a SADIS,
Okay, SADIS. Yeah, I usually use a SADI for that. I sacrifice all the greater curvature so that I dissect here to here for SADIs.
and you will use the same bougie sides or the larger bougie sides?
Yeah, I do not doing exactly the SADI. Yes, and yep, like this. Yes. No, this is okay. Yeah. This is
But
okay.
Gianfranco, let me ask for that. We usually use bigger size of bougie. If the bougie is not available for the SADI, then we will try to stay at least 1 centimeters away from the 40F bougie. So we need floppy stomach as compared to real sleeve if you are doing SADI.
But I think this is a very important information, and say that if you are planning a sleeve gastrectomy as part of a sleeve gastrectomy plus in 2 steps, you have to consider, of course, the distance of antral resection from the pylorus and also the bougie for the volume and the shape of the pouch. So the message for the people is that if you plan a plus to add the second part to the sleeve, please
over here, yeah,
stay at least at the 5 centimeters from the pylorus. And the second, if you stay there, don't push the stapler against the bougie, but to obtain a larger pouch at the volume. Just to comment and to discuss, every time that I started the sleeve gastrectomy, my first check is for the hiatus for the fat pad to exclude that there is I want to see the esophagogastric junction below the hiatus. I want to see where it is. I check before to start, I check the hiatus. I think that this should be very useful in case you plan to change the planning procedure, because the intraoperative diagnosis of the hiatal defect is very high, more than 40%, and the reverse in some cases when endoscopy and the barium swallow indicate a hiatal defect, a hiatal hernia intraoperatively, you don't find the defect in the hiatal hernia. So in my practice, the first step is to check where it is the angle of the esophagogastric junction routinely.
What you do, Professor Ipek, you always check the hiatus before you start dissecting the omentum, or actually you can do it when you go up also?
No, I don't check before operation. Some examination is enough for me.
Well, I agree with Gianfranco that for my operations in every obese patient and every obesity surgery, I also intend to go up and check the gastroesophageal junction and also try to see the left crura at the beginning if I can. If I can't, I will check it and I will come down, and you can see here that Kazu is going to do the same transection of the omentum from here to up. Kazu, you start from the middle of the stomach for your.
That's right. I start from the middle.
Some people start from the below, very close to pylorus. How do you find which one is easier, which one is
for me,
better?
Starting from middle is easier. Yeah, because I'm standing on the right side of my patient,
And
I think that the position, when you started the dissection, the great curvature was right position. Just the landmark should be between the body of the stomach and the antrum and the lower portion, because in that way you can have access easier to the retrogastric cavity. Maybe your tension on the stomach is on down. I will suggest to have a tension medially, not on down, but medially. Okay, medially on with your left hand, medially, and your assistant gently traction laterally, just to see in every step the retrogastric space. Right, this is the way. And say, don't allow that the posterior wall of the stomach stay in front of you, but your view should be every time the retrogastric position. You see, you have the pancreas, the splenic artery in a few seconds, and I think it's very important the traction for the exposition of the field in this way. The first operator with the left hand medially and the assistant laterally, possibly on the same plane, and say, don't change the plane when you go up to the left pillar.
yeah,
Can
I
you,
think-
Celal, can you give some information about the endoscopy of this patient, whether the patient, I probably missed, whether the patient has any kind of sign of reflux, esophagitis, or hiatal kind of hernia found during endoscopy. The second question goes to Kazu. Kazu, do you do endoscopy for every patient before your surgery?
Yeah,
Okay, the first
yes.
question is yours.
The patient has no comorbidities, and about the evaluation of the upper GI endoscopy, it's normal,
Okay.
totally normal.
I think it's better if you retrieve the bougie few centimeters, because the bougie, is there. If you retrieve the bougie 4 or 5 centimeters, should be easy to see the left pillar, because the bougie is pushing the posterior wall of the stomach.
Yeah, I know that.
Yeah, okay. Retrieve the bougie.
Let me ask you, Kazu, bunu aşağı
Yes, I always do an endoscope before surgery. Always, all patients. Because you know that in Japan, we have many gastric cancer. So, yeah, accidentally, I find a few cases of gastric cancer before bariatric surgery. So that I always do endoscope before surgery to rule out any other pathology.
Kazu, do you intend to see a left crura in every patient?
Can you clean the camera, please?
Yeah. Can you clean the camera, please?
Can you clean the
cannot
camera,
see-
please? Because this is a crucial point of the technique.
Okay, clean the camera, please.
Sorry.
No,
And
it's
now I
okay.
have other 3 questions for you. If
Yeah.
at the preoperative endoscopy you find an Helicobacter pylori positive, do you eradicate the Helicobacter before surgery? You consider mandatory to eradicate the Helicobacter pylori, yes or not? And,
Yes, sir.
And
Yeah, okay, go ahead. So during surgery, I
Celal, bir yan odaya söyler misin? İkinci oda yavaşlasın, biraz ameliyatı bitirecekler, yoksa biz burada tartışırken bir yavaş gitsin. Ahmet Siyahbalta'yı birisi durdursun.
Tamam abi, gidiyorlar.
Okay. So I always check H. pylori, and if the H. pylori is positive, I mandatory eradicate before surgery. So there is some information, the paper regarding H. pylori and the complication. So that if the H. pylori is positive, the complication is more in the long term. So yeah, okay. Can I have a gross one? So that I
We will-
always
yeah.
check H. pylori and also the
And I ask my, yeah, no, you can do this one. Or like this. Yeah. And
Kazu, in the meantime, while you are doing your exposure, we are gonna go back to room number 2 and get some
Okay.
information from the second patient, and we will come back to you. Okay, please go slowly, and we'll be with you in a minute.
Go slowly, okay. Yeah, I always watch
İkinci
this
odaya
one.
bağlanalım mı arkadaşlar? Ahmet Siyah, geldik mi sana?
Is the fat part.
Yeah, release the fat parts, yes. Until the, yeah,
Samet, duyuyor musunuz bizi?
until I
I
always
can
watch
hear you.
here.
Okay,
And,
can we just connect Ahmet Siyah and let him explain what he's doing and what is the plan?
First
And
step,
also-
first step, we measured we checked the small intestine. So before starting everything, and small intestine looks can come to the upper sides of the stomach with no tension. After we will be sure, and then we make the liver retraction, and now this is sleeve gastrectomy. Excuse, bir dışını gösterir misin?
Temizler misiniz lütfen?
This is sleeve gastrectomy.
Kameranın ucu
Out
kirli biraz.
part.
Kamerayı temizler misiniz?
Hmm.
Biz öbür odaya bir gidiyoruz. Biz birinci odaya geçiyoruz. Siz kamerayı temizlenince bağlanacağız size tekrar. Kazu, can you hear us? Kazu, can you hear us? Kazu? Can you hear us, Kazu?
I can hear you.
Okay. Now we are on your side. Please do explain what you have done on the left crura and the fat pad.
Yeah. Okay, so that let me explain that this is the left crura, and I already checked this one, the white line, so-called the white line. This is just between the esophagus and the stomach, and I always take out the fat part here to check the angle of his properly. This is the angle of his, right? And grasp, please, yes. So I always already dissect here, and I think I need to dissect a little bit more. So, no. Please hold here. Yeah. Okay.
Bizi duyabiliyor musunuz ama?
And then I need to dissect a little bit adhesion of this place.
Celal, biz seni duyuyoruz canım. Okay, perfect. You're just clearing up the posterior wall of the stomach now?
Yes, and the 4 centimeter.
What I do is, even if I don't try to start my transection at 2 centimeters, but I try to release all the adhesions till the pylorus on the back side of the stomach, in order to avoid any surprise that I can get when I insert or when my assistant inserts the staple inside, because sometimes I do this robotically and assistant put the staple inside, and it might cause some trouble in going through the pancreas. So I try to clear up the backside of the stomach all the way through to pylorus.
All the way to pylorus. Oh, really? Oh, okay. For sleeve gastrectomy,
you did a perfect exposition of left cruise, and this is the only way to obtain a total fundectomy with resection. I agree completely with you. As concerned the posterior adhesion of the antrum, if you don't free all the adhesions, you can have a right position of the bougie in the antrum. And so when you
that's too much. That's too much.
With the first, okay, with the first stapler, maybe you can have a twist of the first stapler line, of the first part of the stapler line. That,
So this is the bougie.
that's fine. That's fine. That's the right way. What kind of cartridge are you using?
So
Which
I
cartridge?
I started from black cartridge. So I know that Signia is one of the best stapler, and this is very promising stapler, but I usually use this black stapler to avoid.
You can rotate the
Yeah.
Staplerin black tarafını üste alırsanız arkadaşlar kim kullanıyorsa Signia mı o?
Yeah.
Signia, evet hocam. Can you switch the sides?
Huh?
Can you rotate the stapler
Okay.
to have the blade upper side?
No. I usually use a blade on the.
They want to see. They want to see.
Okay. Really?
No problem. If you are happy with this, Kazu, you can carry on like that. I just wanted to show the people inside the room that, yeah, you can do it like that.
Yeah.
Yep.
Okay. I usually put the anvil side on the top and the stapler side on the under the stomach. And the important thing is to have some position between the stapler and the gastric angle here. This is the place that we have stenosis. Okay, let me see here. Okay, we need to check the posterior wall.
That's right.
Try to keep. Yes, you must close more.
Yeah. Close more.
Okay, while you are firing, we will go to second room and we will come back to you in a minute.
Okay.
Bizi ikinci odaya bir bağlayın arkadaşlar.
Hello.
Ekranı da ikinci odaya alın. Ahmet Siyah Balta ve Samet sizdeyiz. İkinci odadayız. Bize bir açıklayın ne yaptığınızı.
We are creating the Porsche, gastric Porsche. Please let me show. Now, this is EG junction, and this is the.
Samet.
There are some.
Samet, the camera is not very clean, so if you can clean it up a little bit, and we can see better.
Now.
Yeah, please. Yeah, you can explain what you have done by now, and yeah, we can carry on.
Now, camera is good. Camera.
It's much better now. Yeah.
Okay. Now, first of all, there are some adhesions between the spleen and the sleeve, and we divide them with energy device, and yes, and we make the left cruise ready, and after that we get the
what's going to be the size of
the patient, and started creating a Porsche. During this process, we selected between second and the first, second vein, and second and third vein. This was the third vein, and it's approximately 50-60 cc's. We think about it, and now we will transect the stomach for the first step of Roentgen gastric bypass.
May I ask you something? If I'm doing one revisional surgery on a patient who had a sleeve before, if my plan is doing a Roentgen gastric bypass, I intend not to do a very small stomach pouch, just in case if we need something to do with any complication. So what is your intent to do the size is what, I mean, you said 60 milliliter, 50 milliliter, but what your intent to do the size of the pouch is going to be 5 to 6 centimeters from the junction, or it's going to be a little bit longer than that?
Actually, here, yes, you are right. We are always be prepared for the complication and for the negative things during the surgery. But I think there are some space if you leave any stapler misfiring or something like that. We have enough space for one, because, you know, if you make a bigger push, restrictive component of the Romaine gastric bypass will not work properly. So, but you are right. I think this.
So we probably lost the connection and the screen is also gone. We can go to room number 1, please. And you adjust the quality of the view in the meantime and the connection. Bizi birinci odaya alın, siz kaliteyi ve görüntüyü kontrol edin. O görüntünün kalitesi de kötü, bunun kadar iyi değil yani. O kameradan değil, bir sorun var o tarafta. Okay, Kazu and Celal, we are back to you.
I'm listening to you. Oh, yes, I'm listening to you.
Yeah,
So-
just explain what you are doing. You're just releasing the adhesions
There are
behind.
some adhesions behind the posterior wall, on the posterior wall, and I asked my assistant to put the stomach area. Yeah.
There is one question from the floor, and Professor Sumer wants to know that you always clear up all the adhesions on the posterior wall, or you leave some of them if it is very close to the left gastric artery.
I try to remove all the adhesion, but of course, this is a little bit dangerous to, to dissect around the left gastric artery. So this is enough. What I'm doing is, what I'm doing is just make a proper way of inserting a stapler. Yeah, I dissect this way, right? Okay.
Romaine gastric bypass. I usually use Nathanson retractor. As you know, there are 2 different methods.
So we are in room number 2 now. Please move the screen to room number 2. İkinci odaya geçelim arkadaşlar. İkinci odadayız. Yes, Samet, we are listening.
Of course, it.
Now we are preparing the gastric pouch to divide, and during this process, sometimes big livers can cause problems.
Arkadaşlar yukarıdaki küçük görüntüyle aşağıdaki görüntünün kalitesi aynı değil yani. Lütfen o ikinci odaya bağlandığınızda o kalite bozuluyor. Burası birinci oda. Birinci odanın kalitesi tamam. Ama ikinci oda kötü yani. Küçük ekranda güzel, büyük ekranda darmadağın oluyor görüntü.
I think this is a very important technical issue. No, we are in room number 2.
Room number 2. Yeah.
Number 2.
So this room why
Okay.
pouch is being
Yeah,
created
yeah.
now.
The color of the cartridge is
Evet, soru sana kartuş
Bana
rengini,
ihtiyacı var. Çekileceğim. Yes.
kartuş rengini soruyoruz abi. What is the
It's
color of the
purple.
cartridge now? Purple.
Purple.
purple.
Huh?
Good, purple.
Purple. Yes. Actually, we prepared black one. If we see any thick tissue during the conversion or revisional process, generally we see thick tissue and we prefer black one, but this tissue seems good, seems not too thick. So we decided to use purple one.
Samet, did you check before the
Dr.
firing?
Balta is not. Yes.
Samet, did
No,
you
I'm
check
not.
before?
Yes. I didn't heard the question.
Did you check before the firing stapler? Is there any endoclip on the lateral side of the previous of the sleeve previous in the previous
Yes, sure.
operation?
Actually, yes, we know, and also we have chance to talk with the primary surgeon. Primary surgeon was Dr. Celal, so he didn't use any clips or sutures, and also sure we check because it may cause misfiring of the stapler. Açık onlar.
Okay. Samet, we are back to room number 1 now. You carry on your transaction. We will come back to you in a minute. We can see what you are doing and we will come back to you in a minute. Birinci odaya bir gidelim mi, diğer odaya arkadaşlar? Sesi de kapatıp Kazu, we are back to you.
Okay, great, thank you. So
Yeah,
what
yeah.
I'm doing now is dissecting a posterior wall of the fundus. So important things in the sleeve gastrectomy, we dissect, we cut, removed all the fundus, so that this is to dissect the posterior wall vessel from the fundus.
Just to comment, before you change the port, where you introduce the stapler, you change for your left hand to your right hand. Do you think that this is a good trip? Yes, you do this routinely. Why do you do this? Because in my practice, I never change the hand of the stapler. I prefer to have the stapler every time in my left hand just to follow the route and don't change the angle. Because when you move the stapler from the left hand to the right hand, you change the plane and you change the angle of the stapler. If you want to stay just near to your bougie and to have the left hand position of the stapler, I think it's helpful sometimes. If you want,
Hi, Mahir. Can you hear me?
just near to your
Hello.
bougie
So sorry that the sound was
stapler, I think it's times.
I don't know, the sound is repeating again and again.
Hi, Mahir. Can you hear me?
Salonda sanırım Celal'in mi birisinin mikrofonu açık ve iki ses bir anda yankılanarak gidiyor. Bizim ana konuşmamızın dışında arkada bir yankı var ve bizim söylediklerimiz 3-5 saniye gecikmeli olarak tekrarlıyor. O yüzden de karşı taraf alamıyor. Buradaki teknik arkadaşla oradaki teknik arkadaş lütfen konsantre olup onu düzeltir misiniz? Rica ediyorum.
camera.
İki mikrofon açık muhtemelen. Kazu, can you hear us now?
Yes, but okay.
Perfect. Okay, now you are trying to do your transaction on the fundus. You cleared up the posterior wall. We can
That's
see
right.
properly, and I can see that you are staying far away from your bougie.
Yes.
And
Because I embed the whole step line.
okay, what is the length that you will leave away from the esophagogastric junction for the last stapling? 1 centimeter?
Usually
or
1 centimeter from there.
1 centimeter.
1
Okay.
centimeter.
Okay, perfect. We will go up to the second room. We will go back to the second room and we will come back to you. Okay?
Okay.
Carry on. You will be finishing your transaction in the meantime anyway. Şimdi bizi öbür odaya bağlarken lütfen benim demin söylediğim gibi sesleri kapatarak bağlarsanız yankılanmadan gidebiliriz arkadaşlar. Samet, bizi duyabiliyor musunuz? Ahmet Ziya Balta,
Gayet iyi.
bizi duyabiliyor musunuz?
Şu an duyuyorum sizi. Rahat duyuyorum.
Okay, şimdi explain what you are doing now. So we can see that you
Now,
prepared pouch for the
he will use circular stapler for making the gastrojejunectomy. So gastric pouch now created, as you see, and now
You don't need to continue to
Now-
dissect the posterior wall of the pouch. It's okay. You
pouch
don't
is okay.
put a bush inside. If you put a bush inside, you have a good shape and you decide where to perform the anastomosis.
Yeah, put your bougie inside and push the bougie till the tip end, and you don't need to dissect the posterior
No.
wall a lot. That's perfect,
Bougie-
perfect pouch that we can see.
I agree. I agree. The posterior wall is perfect. You don't need to dissect them. Okay. You have a very small pouch, good pouch. I
Now-
like it. The bush is coming. And
now
now,
bougie is coming. 45, yeah.
perfect.
Yes.
Yeah, right. You put a sponge on the backside of the stomach, and you have your pouch in front of you with the bush inside. They are suggesting, please do here the anastomosis, right?
Yes. Now
Yeah.
he is preparing
Push
for
the
anastomosis.
bougie. Push the bougie. Don't retrieve the bougie. Push the bougie inside. That's help you.
No, he rejected to push the bougie, and
No, no, I agree. I agree with Ahmet Ziya, and he's trying to cut the tip end on that side. So without bougie, sometimes it's much easier to cut and take it out. If you are going to make a hole, you need to push the bougie, make a hole on the anterior wall. But Ahmet is trying to take that corner out, for which you don't need to put the bougie. But now you can push the bougie now to see the lumen of the pouch. So perfect, yes. If you push the bougie now, you can see the lumen of the pouch.
ver bakayım onu.
Ahmet tabii Trabzonlu olduğu için hani çok öyle söylediklerimizi yapmaz yani. Kendi bildiğini yapar. Thank you. Can we also connect Ahmet Ziya Balta? Can we hear him as well?
Yes, yes, I hear you, but I have no microphone.
But we can hear you now. Even if you talk now, we can hear you. You don't have microphone, but I told that if you can push your bougie now, we can see the lumen and the size of the lumen. Yeah, perfect. Okay, we can see it now.
Yes, I will put the person.
So just to give some tips and tricks, the dissection of the mucosa, submucosa, and all the wall of the layers of the gastric wall is a risk in this phase. So a good suggestion for the people that will start to do this job is begin with a small hole. I prefer to use the hook and then you enlarge the hole. Don't go directly with a big hole, because in this way, when you go inside the lumen, you can enlarge the hole how much you need. Because the dissection of the layers are one of the possibility that can occur in this phase.
You are going to use the circular stapling for the anastomosis, and you're going to put the circular persitring sutures around it now.
Yes, he will make the pursing sutures first, and later we will insert the anvil of the circular staple.
Okay, we will go back to the room number 1. They are actually trying to cover the suture line, staple line. Okay, let's go to room number 1. Thank you. We will come back to you in a minute, Ahmet. Tamam, dur abi. Biz öbür odaya geçelim. Başla süre. Soru bu taraf için mi, o taraf için mi? Bu taraf için. Burası için mi? Dur geleceğiz. O başladı da köşeyi görmek istiyorlar. Kazu, we are back to you and you are putting the sutures on the staple line probably. Can you just explain which kind of suture you are using, and
In the rational.
yeah, I know Etibond. Kazu, can you hear us?
Yeah, yes, I can hear you.
You
Usually,
use Etibond or you use Vlog? It looks like Etibond.
yeah, it's a same with Etibond, but no Etibond here, so I don't know the name of this one.
Dosa.
Yes,
Dosan Weigel.
Yeah.
Okay, you will just bury the staple line now or no?
Yeah, I inverting the staple line. I invert all the staple line because one of the reason is that I used to have no reinforcements, but in the beginning of sleeve gastrectomy, it leaked my first or second case. And then I started to use buttress material, and then it leaked. So I changed my style to suture or the staple line or secure. But using a staple line, suturing a staple line with inverted procedures, so that you need to have a little bit distance from the staple line of using a
What's the rationale of the running suture that you are performing? To reduce, to minimize the leak or bleeding?
Both.
Do you know that there is no evidence in the literature that this running suture helps? And the literature said that if you put a running suture, if you are a good surgeon like you, but if you are a beginner, you can have a bleeding, hematoma, and other problems.
Yes.
First. Second, you are reducing the lumen of the bougie and of your bougie with the running suture. And the other problem is that
Okay, so that I agree with you. There is no evidence, but all surgeons have their style according to their experience, not only for the evidence. So because the oral surgeon,
you see the bleeding, dude, there was no bleeding. Now with the running suture, start bleeding. You see?
Huh?
I agree, Kazu, and we all act, as you said, based on the experience and the previous knowledge, not the papers. We follow the footsteps of the previous surgeons who educated us, and I believe there are some evidence also. If you do overlapping sutures on the staple line, it's not probably good for controlling the bleeding, but it definitely helps to decrease the rate of the leak. And since the Chinese stapling era, I intend to do running sutures on the staple line. But I have to say that if I'm using Signia and the triple stapling from Medtronic, I never bury them. I just left it alone. And you know, there are studies even from us comparing the leak rate. For the leak rate, if you want to talk about the leak rate based on the buttressing material, you should complete at least 10,000 cases to find the real number. So most of the studies, apart from the Michel Gagne studies, which includes 12,000 cases in one study, includes less than 1,000. So no meaning for the statistical conclusion. But as you said, based on the experience of the surgeons, we try to do running sutures, and I can see that he's not doing the running suture only. He's actually inverting the staple line inside, which I love it.
Yes,
so,
that's right.
So you are inverting the staple line. This perfect, burying the inside. And also he used the 39F bougie, but he left something like 1 centimeter away from the bougie he was. And then he has plenty of places that he can actually do the inverting. The size of the sleeve is not gonna get much narrower than he planned. So it's going quite well, but I agree with Gianfranco that suturing might result in more bleeding sometimes.
Did you reduce the preperitoneum? What's your preperitoneum now? 12, 15? How much it is?
Basınç kaç arkadaşlar? Celal 12 mi 15 mi? Preperitone'u azalttınız mı? Okay, probably we lost the connection. We can go to room number 2 and there was some one question from Dr. Sezer Bulut. Ahmet, Samet bizi duyabiliyor musunuz?
Evet, duyuyoruz.
Samet bir soru var. Sezer soracak. There's a question for you for the pouch, probably for the pouch size. Sezer Bulut is going to ask one question. Sezer.
Samet abi,
dinliyorum.
could we have a preferred mini gastric bypass for this patient? Or why didn't we prefer mini gastric bypass? Thank you.
Yes,
Samet,
actually,
yeah, you got the question.
mini gastric bypass is a good conversion for weight regain. But as you know, if there is a reflux, generally we prefer Romaine gastric bypass. This patient has no reflux, signs, symptoms, or endoscopic findings, or hiatus herniation. So both of them can be selected, Romaine gastric bypass and one anastomose gastric bypass for this patient. If actually we talk about it before the surgery and we decided to make the long biliopancreatic lymph gastric bypass, it prevents the patient from bile reflux to the stomach and also good conversion method for weight loss. But it's both of them can be selected.
Okay, there is also one more question from Orchun. Orchun is going to ask one question. I agree, Samet. I mean, if the patient is having some symptoms of reflux, and if I'm going to do revision, I will not actually prefer MGB in this patient. But if there is no reflux symptoms and if there is a obstruction or stricture just below, very low to stomach, I try to go a little bit upper than that and try to do MGB. But size of the stomach is gonna be not the standard size for the MGBs. So if you are going to do a small size stomach, it's much better to do RMY. Orçun.
Cildi değil mi?
Türkçe mi sorayım?
Okay.
Samet abi merhaba.
Merhaba.
Orçun ben abi. Ziya abi elinize sağlık. Çok güzel gidiyor. Ben şunu merak ettim. Şimdi bu 22 yaşında bir hasta diye prezente edildi. Yanlış hatırlamıyorsam.
Çok özür dilerim. Baştan alır mısın soruyor Orçun?
22 yaşında diye prezente
Evet.
edildi. Doğru değil mi?
Evet, evet.
Şimdi slivin şekline baktığımda hani slivde böyle bir fundus genişlemesi ya da bir dilatasyon gibi şey gelmedi bana. Mutlaka kilo alımının bir sebebi vardır bu hastamızda. Hani Roentgen'e geçmeden böyle sleeve plus prosedürlerden bir tanesi yapılıp denenebilir miydi? Merak ediyorum. Hani Roentgen uzun vadede hem vitamin mineral yönünden biraz sıkıntı yaratacak. İşte safra yollarına erişim yönünden sıkıntı yaratacak. Yani bunu antrumun altına böyle bir anastomoz yapılabilir miydi?
Actually, yes, it can be done, but should it be done? I'm not sure because we don't have enough evidence for using sleeve plus procedures for sleeve revision. So,
and also,
we
as
have-
far as I know, patient wanted to have Roentgen gastric bypass. This is the
Yes.
most important thing. Patient wanted to have Roentgen gastric bypass. Şimdi diğer odaya, birinci odaya
bir Bana bir gidelim. çamaşır-
Birinci odada sütür hattı kapanıyor. Oraya bir bağlanalım lütfen. Kazu, we are back to you. Would you like to say anything now?
Yeah.
My question is, if you do overlapping of the staple line, I mean inverting the staple line by using sutures, do you go all the way through till the end of your staple, start of your staple line, or you finish somewhere like this as you are doing, and then get some momentum for the fixation of the stomach?
No, I don't put momentum to the stomach. Just cut, please. Cut. Just use the suture like this at the end, but I do gastropexy. Yes, I'll show you later. And this is my second suture, connected with the first suture. And I know that the good things of the inverted staple line is we can trim the size of the stomach. You know that if I make a very close to the bougie, sometimes it causes a tearing of the tissue of the, using a stapler. But if I a little bit far from the bougie here, so there is no need to worry about tearing the tissue. But of course, the big size of the stomach is not good for the weight loss, so that I can trim the size of the staple of the stomach using this kind of suture. And also that the important things of the sleeve gastrectomy is not rotating. Sometimes the staple line rotates, but we can also adjust the rotating of the staple line. So that you can see here, my suturing line here is always the opposite side of the small curvature. So I want to make a beautiful line of the suture line. Of course, it's according to the skill of suturing. Sometimes it's called bleeding, but if you are good at suturing, please hold this one. So this is my favorite style, okay? And I ask my assistant to hold the stitches to give me a better view. So I do a Luema gastric bypass and also the 3+ procedure or anastomosis is hands-on. And personally, I like to do suturing. And so that I always bring my instruments of my left hand grasper. This is a Jubeki, and also my needle driver to all country I've ever been for live surgery. So this is my samurai sword. Always bring these two. Yeah, suturing is good for secure. And this year this year of the World Congress of Endoscopic Surgery, David Lomanto for the championship of suturing, laparoscopic suturing in the Congress.
I know the Imamura and some other people will be there as well. And
Yeah, that's right.
the, what I would like to know is, I mean, when we start doing this in our country, mainly, but most bariatric surgeons here, we intend to fix the omentum all the way through, either all the way through with the suturing to the staple line, or we can get at least 4 or 5 sutures to fix the omentum to the stomach, because the omentum will actually prevent the stomach to go up and do some kind of turning around and causing the deformity or stricture of the stomach. I was just wondering whether you are going to put some kind of sutures like that when you finish this continue inverting sutures, or you are going to leave it like that?
I'm going to use some omentum, gastropexy to here to avoid the kinking and the migration to the stream migration. So I'll show you later after these procedures. Yeah, it's almost done.
There's one question also. What is the patient's position? It's the French position. You are in between the leg, or you are actually on the right side of the patient?
Yeah, I'm on the right side of the patient.
American position.
American position, yeah. That's American position.
You prefer to do all cases like this, or?
All cases.
Okay, perfect.
Yeah.
If you don't mind, you are finishing now. Before you start fixing the omentum, please wait before fixing. We will come back to you. We will go to next room, and they are firing the stapling for the room-Y at the moment. We will go there and come back to you. Okay, but please wait before fixing the omentum. Okay, I need you to explain. Perfect, thank you. İkinci odaya geçelim arkadaşlar. Samet. Samet, Ahmet Ziya, can you hear us?
Beni duyuyor musunuz? Duyuluyor mu konuşmam?
Evet, şu anda duyuyoruz. Sametciğim, Ahmet Ziya bize herhalde circular purse string'i koydu, yerleştirdi. Bir iki tane de
Orada
koyacak etrafına.
Açıklık. Evet, orada bir açıklık olduğunu gördük. Yani purse string aslında tam kapatmadığını gördük şu kısmın. O yüzden orayı biraz destekleyip daha emniyetli bir anastomoz yapmak amaçlı ekstra dikiş atıyoruz şu anda.
Okay, perfect. What is the size of the stapling that you use for this one? 21 or 25?
25.
Okay. Ahmet, you always prefer 25?
Orayı her zaman 25 mi kullanıyorsun?
Yes, always. Because 21 is maybe cause of the stricture.
Okay, do you sometimes use linear stapling for the room-Y as well, or just always use circular stapling?
Always use the circular stapler.
Especially for the revisional cases, you can probably choose this one, but on the primary cases, Samet, you choose linear stapling sometime?
Yes, not sometimes. I choose always linear stapling anastomosis, yes.
Do you have any experience with the Orville?
Bad experience. We stopped using it.
Not for bariatric surgeries, but for gastric cancer surgeries, yes, I use Orville.
We used to start with the Orville initially. We had some trouble with the Orville, and then we gave up, and we are using this kind of traditional circular stapling for the room-Y as well. But I agree with Samet that most of the time I try to use linear stapling for the room-Y as well. Okay, now
actually we didn't. Orville seems a good idea, but using Orwell is really difficult, really difficult. So linear stapling, actually, for observing anastomosis has some advantage. For observing anastomosis, less structure, less wound infection, because we have to insert the circular staple without trocar. So circular stapler. This is our fault. Yes. Is there any comment?
Ahmet, before you fire, we would like to know the limb length for the Roux-en-Y, and please also explain, are you measuring the whole length of the bowel in every patient before your decision? And also the second one is what is the limb length for the biliary pancreatic limb, and also on the common channel and the enteroenterostomy from the pouch? If you can give me the length, also we will be grateful. In the meantime, while you are thinking, we will go back to room number 1 and then we will come back to you in a minute. Birinci odaya geçelim arkadaşlar. Okay, Kazu, we are on your side and you can start fixing your momentum and please explain. We are listening. Kazu, can you hear us? Arkadaşlar birinci odanın sesine bağlanamadık.
No, they are preparing.
We can hear you now. Kazu, can you hear us?
Okay, okay, I can hear you very well.
Yeah.
So
now
usually,
please do start your explanation. Yeah.
yeah. Usually I stitch the here, not use momentum. I use here to prevent the rotation of the stomach, and also that I use put a little stomach to avoid the intrashock migration. Oh, this is all.
You are putting the suture on the omentum or the meso of the transverse colon?
Mesotransverse colon. Oh,
Yeah.
this is, yeah, this is not good. I show you again. Can cut, please.
How many sutures are you going to put? Just one here only, or are you going to go carry on with a couple of sutures?
A couple of sutures. So you, please.
Okay, perfect. I start using this, and when I use triple stapling and signia, I do fix the omentum by putting 3-4 sutures only. But if I'm using the other staplers, I always intend to invert the staple line as you do here. But I can see that you invert the staple line. It doesn't matter whichever staple you use.
Yeah.
Is that right? Yeah.
Yeah, I agree with you that Signia is the best stapler ever, and Signia can reduce the bleeding from the staple line. That's true. And but I always invert the staple line. Please. The one of the reasons to invert the staple line is trim the size of stomach.
Do you have experience of any case that you came back for a second operation, for example, for a cholecystectomy? Did you have a look of this suturing that you are doing with the omentum and the wall of the stomach, or what's happened, if it's still there on, yeah, just curiosity. I don't do this because there is no evidence that this help in any way, and there is no rational. But I understand that several surgeons around the world continue to use to fixate the omentum just for tradition, for I don't know, for daily practice. The surgeon prefer don't change the practice when everything going well. But do you have experience in any case that you came back for example, a cholecystectomy or umbilical hernia or other procedure? And did you have a look to the omentum fixed to the stomach? What happened?
I did fix, yeah, but yeah, that's okay. That's fine. That's fine. And this is okay. And of course, that I do experience. I have experience of cholecystectomy after bariatric surgery, but usually the adhesion around here is a very small minimum after inverting the staple line. And regarding the omentum, so there is some adhesion of the omentum to the staple line, but it doesn't matter.
Can I?
Okay. Grasp, please. Yes.
Okay, it looks perfect. And you'll check the bleeding points. And are you going to do methylene blue test for leak test?
Excuse me, madam.
Yes.
So
Kazu, can you hear us?
yeah, I think the leak test. Leak test, please.
Yeah,
I want to ask something to the audience. Can you hear me?
yeah, who is talking?
I am Celal.
Yes, Jalal, we are hearing you. And if you get close to the microphone, it's going to be much better.
Can't handle it now.
Okay, show me.
Do you hear me now?
Okay.
Yes,
Go ahead,
perfectly.
go ahead. Yeah.
Yes. What do you think about
Okay. Okay, that's fine.
inserting of the staple
That's fine.
line?
That's great. Thank you so much.
That does it cause more pressure for the integrity of the staple line? What do you think about this? The inserting
mean-
of line.
It's okay. And then you can remove the yes.
For sure.
You mean the suturing the staple line?
Suturing the staple line with inverting it, does it cause more pressure to the integrity of the staple line?
No, I don't think so.
No, actually, you are not suturing the staple line. You're just inverting the staple line, which doesn't make any harm to the staple line. It is the way to avoid to disturb the staple line. If you do suture the staple line, most likely you will disturb the staple line. But now you are just inverting, and also putting suture on the staple line has been shown that it increases the bleeding rate. It doesn't help on the leakage rate as well. Most of the studies suggest that you have to invert the staple line. That's why he left his stomach a little bit floppy. He wasn't very close to the bougie. He stayed away from the bougie while he was firing the staple, as we have seen. And you can see that he put a couple of sutures on the antrum, close to the antrum, just to keep stomach on a good shape. As Gianfranco said, there is no evidence to suggest that, but physiologically, I believe that helps. But again, there is no study and there is no evidence to show that it helps, that it can help to avoid the kinking and the migration of the stomach to up. Because if there is a adhesions between stomach and the liver, there is going to be kinking anyway. What do you think?
Yeah. So that to avoid the kinking of the stomach, I suture the staple line. If the staple line is out, they may tend to have adhesion to the liver and then the kinking. I have one case of the adhesion of the liver cause kinking, and I have to have a revision surgery to get us because of the severe GERD. So that's yeah, that's my experience, no science, but I try to avoid the adhesion.
So honestly, with the introduction of triple stapler technique, I give up the reinforcement. Before I used routinely the SIM guard, the absorbable tissue reinforcement with the triple staple line technique.
You can take it out.
I give up to reinforce with the buttress material the staple line.
You want to press the brain? It's up to you.
I think that the component of
Neighbor.
the
Actually, that's my-
right to avoid the
İkinci odaya
kinking.
gideceğiz
I press the
çocuklar
brain.
birazdan.
Nothing changed. So that after
Okay,
that-
sorry to disturb, but they are starting to fire a stapler on the other side. So,
Yeah, okay.
Kazu, we will come back to you. We have to go back to the room number
Thank you,
2
Maki,
now.
but it's almost finished. Just to take out the specimen.
Okay.
Yeah.
Okay.
the end of the surgery.
Okay, we can finish your side. You will take your specimen out now. And we would like to thank you for this nice case. And we would like to congratulate you, and everybody in the room are very happy. Thank you for for this successful case.
Excellent
You can see
surgery. Very good.
the clubbing. And we will go to room number 1 for the Roux-en-Y anastomosis now. Thank you, Celal. Thank you. We will come back to you, Celal, to introduce all people inside the room again. Okay?
Right.
Yes, we are here.
Room
with
number 1, room number 2,
Dr.
please.
Kasama, me and Dr. Almir, and nurses. Our nurses are Sevda and Ece. We are happy to have you here, and it's a big honor for us. Thank you very much.
Biz de hepinize çok teşekkür ediyoruz arkadaşlar. Thank you, Kasama, and hope to see you shortly.
Yeah, my honor. Thank you. Take care. Bye.
Okay, go to room number 2 now.
So much. Thank you
very much.
I really appreciate
Good
it.
job.
Samet sendeyiz. Sizle devam edeceğiz sonuna kadar. Öbür taraf bitti.
Tamam, harika. Biz şimdi enterotomiyi yaptık. We made the enterotomy and
Ölçüleri bir can you give some information about the lengths, limb lengths? Where are you planning to do the anastomosis? Where is the place that you did the enterotomy?
This is 1 meter from triceps ligament, 100 centimeters. Deliği göremiyorum. Deliği gösterir misin bana? Şu. Çamaşır klempi. Excuse us. Yes.
No problem.
Hazır mı? Kamera.
100. santimden anastomozu çakacağız. Sonra kesip onu 50 santim aşağıya indireceğiz. Doğru mudur?
Actually, we are planning.
Yoksa %150 mi yapacaksınız?
Ameliyat öncesi konuştuk. 100 gastroloji 100 santim distaline yaklaşık 200 santimlik 2 metrelik bir malabsorptif komponent, 100 biliopankreatik limf, 100 de alimenter limf olarak. Proksimal bir ameliyat olduğu için bağırsak uzunluğunun tamamını saymayalım diye zaten şey yaptık. Hani robotic gastrectomy bypass'ta bağırsak uzunluğunun tamamını saymanın çok gerekli olmadığını düşünüyorum.
Şöyle standart Roux-en-Y yapsaydınız hani 50'ye 50, 50'ye 100 tamam ama 50'ye 150 ya da 100'e 150, 100'e 100 yaptı. 100'e 100 de kabul edebilir ama 100'e 150 yaptığınızda slightly long limb, then we need to count whole length of the bowel to make sure that patient has
enough bowel length for the common channel. Okay, we will see. And so this is the 100 centimeters you are going to fire, and then you're going to go 100 centimeters down to do your enteroantrostomy, which makes you to create 100 centimeters of biliopancreatic lymph and also 100 centimeters of alimentary lymph. And then common channel, you don't know the length of the common channel. Is that right?
Bir saniye ben sana söyleyeceğim onu. Şuraya bağlandı.
Biraz daha sıkmam lazım. Tamam.
Bir hafif gevşet yukarı. Bunu gevşeteceğim onu. Hafif gevşet. Gevşet şimdi. Geri doğru çek kendine.
Ne yaparım ederim? Vasıtayı silip nasıl ikna ederim?
Kapatsınız.
Samet, yani ince varsa bence yukarıdan biraz kendi etrafında sola döndürmeniz lazım. Orada ince bağırsak içeriye girecek aşağıda. O fonksiyonel bir tıkanıklık yapabilir. Oradan. Evet, oradan biraz yukarıya doğru, superior'a doğru döndürürseniz o şey açılacak. Evet, evet, evet, evet. Süper oldu.
Any question? We will fire. Tamam, gönder. Tık deyinceye kadar çevireceksin. Sonra şey, bir tane mor alırlar bize. Çevir abi. Çevir. Tık deyinceye kadar çevir. Evet. Evet. Güzel. Kapat lazım. Bu şeylere bakacaklar.
Ne oldu benden? Evet. Gastrojejunostomy is completed now. Evet.
Bir tane mavi şey hazırladık. Mor ya da şey.
Çamaşır ver.
Sarı da olabilir. Hem rengi.
Çamaşır ver. Mahir abi %100 için saymak gerekli gibi bir şey mesaj almadım değil mi? Ben demin burada
%100
biraz...
için yani %100 için olabilir ama yani bazen hastanın total bağırsak uzunluğu 3,5 metre olabiliyor. Sürpriz yaşamamak için nasıl olsa girmişsiniz, içeridesiniz, revizyon bir de. Yani saymakta yarar var ama %150 yapıyorsak, 150 ve altına iniyorsak, long limp oluyorsa mutlaka saymak lazım. Çünkü malpractice yani o saymadan oraya yapmak. Yani bence yer varsa hani aşağı doğru bakılabilir. Şart değil ama %100'de de bakarsanız bence iyi olur. 200 çünkü zaten şeydeyiz yani %100 olduğunda hala jejunumdayız yani sonuç olarak. We can see the anastomosis perfectly and I can see that you're going to cut from that part. So you're going to fire purple or blue? Which one you prefer on this place? Or white?
We are waiting pan carpet.
Waiting for white one. He
Buffer,
didn't accept the purple or cutting the small intestine and waiting for the white 3 staples.
Perfect. If you have white, it's better. If you don't, you can use blue. If you use purple, then you have to bury the staple line because it's gonna bleed. I mean, purple for jejunum is not suitable. Okay, any question from the audience? Gianfranco? Professor
No,
Peck?
just yesterday we discussed about the different method to perform the gastrojejunostomy. This is one of the option. Maybe is not at the moment is not the first option in the world. The linear stapler anastomosis is the most diffuse procedure, but anyway, is a well-described technique. In my view, is increase the cost because you need the circular stapler, increase the risk to have a ventral defect of the enlargement of the trocar to 2.5 centimeter, and the opening of the bowel is one step and you can avoid. If you use the linear stapler, you don't open the bowel like this, and is cost effective because just you have the stapler, linear stapler, one cartridge more, and you complete the procedure. But I understand that a surgeon standardized the technique using the circular stapler, and in his hand gives a good results. Will continue to do this, but anyway, consider that there are other options to do the gastrojejunal anastomosis and sewen with the linear stapler, and both of them are equally safe. And at the moment, the most diffuse procedure is the linear one. The anastomosis is perfect, but anyway, you have to offer all the technical possibility to complete successfully this procedure.
Tamam. Evet. We changed our decision. We will use the purple one because we couldn't find the other one.
Why do you put the stitch before to have the blue test?
I see the...
You know, before you complete the blue test, and then you check if you need to put more stitch.
The bleeding prevention.
Orada bir kanamalı bir yer gördün.
Evet.
He told that he saw a bleeding point there, and this suture is only controlling the bleeding.
Are you using a purple cartridge for the small bowel? I know the brown.
Purple.
I know purple.
Actually,
They tried to find the white one, but they
And
couldn't
why-
probably find.
Why purple?
Because they couldn't find the white or blue in the theater. That's why they are using
Oh.
purple.
Sorry.
Samet bulamadınız herhalde beyaz ya da
evet,
mavi.
evet, ondan dolayı.
Mecburen,
Kanal değil.
so they are using purple because it wasn't available at the theater. Now,
Yes, but anyway, the proper should be bronze.
exactly.
You are freezing. Okay, now you move again.
We will count. Şu işaretli şeyi varsa 10 santim işaretleriniz.
Please, can you repeat again the length of the biliary limb?
100 centimeters.
100 centimeters.
Yes, 100 centimeters from thrice to gastrojejunostomy.
To the 100 centimeters.
Can I ask a question?
Biliopancreatic limb.
Yeah.
This
Samet,
device, excuse me,
Samet?
this device, I can hear you, Azizan.
Okay. She is 22 years old and 100 centimeter bleopancreatic limb. In terms of the iron deficiency, is not a more, what do you think? I think it's a little bit more. What was the BMI of her?
40.
40. I think it should be
Actually, before sleeve gastrectomy, his BMI was bigger than 50, 62 before sleeve gastrectomy. And he gained 20 kilograms and the minimum weight she saw is minimum weight seems 70. 70 kilograms still overweight for her. So yes, I understand your concerns, but I think short bleopancreatic limb, Roux-en-Y gastric bypass is almost restrictive surgery. Because, you know, if the patient continues to eat or drink sugar things, it means you don't have any malabsorption or hypoabsorption. Because simple carbs, simple sugar can easily be absorbed from the jejunum, and it doesn't need any bile or pancreatic juice, anything. So if the patient only make 50 centimeter hypoabsorption, I think it will end with the, probably it will end with the weight regain. Weight regain in the early period. So long limb Roux-en-Y gastric bypass seems good. Also, when we look for iron, actually, the patient, she has to use multivitamins for lifelong, even 50 centimeters or 100 centimeters. The primary Roux-en-Y gastric bypass, which I choose, 50 centimeters bleopancreatic limb and 150 for alimentary limb. So complete malabsorptive component, 200 centimeters. So this is 200 centimeters too. So I don't think it's too much. Arkadaşlar şu kulağımdan düştü de bir baksana.
We can hear you perfectly.
İşaretli nerede? Ha. This blue band, we measured it for 10 centimeter. So 50.
I totally approved your method of measurement, stretch on the instrument. That's the right way to measure the small bowel.
Yüz. Bir 10 daha iyi, 10 santim.
This is the anastomose side.
Evet, sen ona hukla mı değeceğiz? Tamam. Bana bir alet verir misin?
Ver bakayım, hook nerede?
Bana bir alet ver. Gel karşıdan gel. Olur bak.
So the alimentary limb is 1 meter too. 100 centimeter the biliary limb, 100 centimeter the alimentary limb.
Yes, right.
Good.
Oradan girmez o stepler. Biraz daha genişlet istersen.
This step is very important because to have just a small hole just to fit the cartridge. Small is better. Smaller is the hole, better is the performance of the anastomosis and the cartridge inside the bowel lumen.
Şimdi 45'te mi yapacağız? 60 değil mi? 45.
60 beyaz yok. 45 var işte. O yüzden beyaz kullanacaksak mecbur 45.
Sometimes to put a stitch between the biliary limb, the alimentary limb could be helpful for the position of the stapler, and anyway will be the start for the close of the mesenteric defect.
Bu benim elimdekini sana vereceğim. Sen kamerayı ben kendim alacağım. Şimdi sen büyük tarafı buradan koyacaksın. Tamam mı? Sen bırak şimdi bu ekartları çek. Yani sen bunu tutacaksın. Evet. Al bunu. Buraya tut.
Evet, lineer 45'lik beyazı açın o şeyi.
5 beyaz.
Var dedi 45 ten rengi yani.
Böyle bana daha yakın gel. Sıraya gerek yok. Şimdi bu vaziyette sol tarafın bunu kes. Ver. Önce aşağı doğru yönlendir kemerini. Aşağı doğru. Ya.
45'lik ten renginden elinizde 2 veya 3 tane varmış arkadaşlar. Ben o bilgiyi aldım. Bir yerlerde sıkışmış olmasın. Gelmiş bir tanesi işte. Evet.
This is 45 millimeters.
It's 45. Okay.
45 is fine.
It's okay. It's fine.
It's fine.
Next step, follow my suggestion. Put a stitch between the two loops because this will help you to introduce the stapler. You know, you have 1, 2, 3 instruments to maintain in the right position the bowel to introduce. If you put just one stitch,
Actually, in the circular staple position, in the linear staple position, şurada. First, I make jejunostomy and divide the gastrojejunostomy. So, in this position, in that time, gastrojejunostomy hangs the jejunum, afferent limb, so it will be easy to make the anastomosis. Yeah.
perfect. Perfect. It's fine. You are in the right place. Anti-mesenteric, the same way.
Görüntüyü, evet. Onu
Gitti mi?
Onu şuradan çık istersen. Bak.
Evet.
Mert. Açmadın. Heh. Çek şimdi. Tamam, direkt çek.
Samet, kamera portunu biraz geri çekseniz daha rahat edersiniz sanki.
Ben tutuyorum hocam.
Kamera.
Ulan bitmeyin. Böyle bana. Şey istiyorum. Şimdi sen şey tutacaksın. Tutmuyorum. Şurasını. Evet. Vlog. Bu değil. Sektör. Evet. Bir tane daha şeye ihtiyacımız var.
Samet, to close this opening, do you prefer the second stapler or hand suture?
Dr. Balta answered hand sewn.
And soon, of course.
He will use the VLAX suture for closing the opening.
Good. This is a barbed suture, absorbable barbed suture, 2-0 or 3-0?
2-0.
2-0. Length of 15
Excuse me,
centimeters.
I'll check 3-0. 3-0. 3-0 for
3-0.
bowel. Yes.
So that was great, great example of the operation ROMY as a revisional procedure. And we are actually in a YouTube channel of Elsa, and also we are in many platforms, and it's being watched by people from Asia Pacific area mainly, but from Turkey as well. And please, Samet, do explain. Maybe I missed something, but you use a VLOC to close this all the time, or you prefer other sutures? Because I use VLOC for that. I feel it's easy to do it VLOC, but sometimes I see people that they use PDS instead of VLOC. What is your choice?
Actually, for closing the small intestine, I usually prefer 2-0 PDS because only it's cost effective, it's cheaper. So and also I can arrange the length easily, because if you are using these VLAC sutures, you have two options or three options: 15 centimeter, 30 centimeter, and 45 centimeters. And here I usually prefer 2-0 PDS, but for sleeve gastrectomy, closing the staple line, I routinely use VLAC, and also closing the opening of gastrojejunectomy when I use linear stapler, I routinely use VLAC suture. Only I do not use jejunectomy because it seems rude.
Samet abi.
Evet, dinliyorum hocam.
Is it matter to close the common hole in this fashion or from staple line to staple line?
You mean perpendicular or horizontal?
Yeah.
Actually, this style I first saw from Dr. Özmen, and it's very good, very useful, because we have no narrow point when we close in this manner. And I always use this manner because if you use a staple line perpendicular horizontal the opposite side, it can cause some narrowness. So this way seems better and also easier.
Thank you.
I totally agree, and thank you, Samet, that you are following my footsteps. I totally agree, and for the PDS as well, for the small bowel, if you can prefer PDF, because I mean, VLAC might sometimes cause some tears on the suture line, because it's, I mean, small bowel is too thin to use the VLAC, and I also try to use PDS, and I close this way because I found it's much easier to do it, and also it's not going to cause narrowing, as he says. But I mean, it's up to the surgeon's preference. If you are happy with the other way, then you can easily use that one as well. We are seeing a very good example of enteroenterostomy, and you are insisting on not to count the whole length of the bowel, even if even when you finish, you are happy with the lengths, yes?
Actually, I didn't understand the question. Please,
So you're
can you
not
repeat?
you are happy with the 100 centimeter of biliopancreatic limb, and also 100 centimeters of the alimentary limb, but you're not going to count the common channel. Am I right?
Yes.
Okay. Okay.
Yes.
Yeah, I mean, as I said, if you do 200 centimeters in total alimentary and
Ahmet, yukarıya
biliopancreatic.
çıkmadan bir tane daha aşağı atar mısın?
Actually,
Orada mukoza
if
görünüyor
we
gibi
decide,
ama.
if
Ahmetciğim, yukarı çıkmadan bir sütür daha aşağı atar mısın? Bak mukoza görünüyor gibi hemen aşağıda.
Okay, he's going to put one more suture
Yok orası abi.
underneath, but
Evet.
yeah.
Bu kadar değil aslında da o içeriden falan bir şey o.
Yani orada delik yok muhtemelen, ama şimdi söylediler, atmazsan oradan kesin kaçak olur. Sen oraya bir tane at abi. Aziz Hoca gördü, bir şey söyledi, yani görmese öyle bir şey söylemez. Şimdi buradan görünmüyor üst üste geldiği için de illaki. You can put one more suture now to complete the suturing on the enteroenterostomy.
Tabii geri gel. Ben gördüm o şey. Aslında değil de. Bakın.
actually, if we make bypass proximally 2 meters, seems safe. But if we make more than 2 centimeters in any way, I think we have to count the total bowel length. Celal burada. Arkada. Bence iyi. Bir şey.
When you close it like that, you put the clip at the end, or you just leave it like that? Cut it and leave it, because VLAC, you don't usually need to put a clip on there, but I always put a clip.
Yes,
on
we will put the clip.
Yeah. Okay, perfect.
Ha? Peki o zaman.
Clip.
Dönelim yok.
Ha?
Cerrah dönün yukarıda.
Ha. Okay.
Side, back side.
Decide to make the second layer.
Second one.
Second layer.
Because of the safety.
Ev sahibi öyle istedi. Host.
Okay, you don't need to do a second layer. It looks quite well. But Celal is there, probably is the, yeah. He wants you to do a second layer?
Yes, yes.
Okay, okay then. after this live surgery, we will have 10 minutes or 5 minutes break, or you want, we can carry on with your speech?
10 minutes break.
Okay, we will have
But,
10 minutes break.
We
and then
discussed about the closure of the mesentery defect, the Peterson space.
we'll do it now.
We will do now.
As soon as he finish, as
We
soon
will
as he finishes the second layer, we will see whether he's going to close the Peterson hole or he's gonna leave it open. In the meantime, if you like, we can start talking on the, what's your preference? You close the Peterson hole in
All
every
the
patient?
time, it's a part,
If
it's
you do-
mandatory part of the procedure.
For the RMY, or you intend to close for the one anastomosis gastric bypass as
One
well?
anastomosis, no, Maroon Y, both the mesentery defect, the Peterson defect, all the time. I think that the data are so robust that is one of the step of the procedure. It's not an options. It's like to close the trocar. If you have the trocar site more than 5 millimeter, you have to close the trocar. The same is for the mesentery defect.
So, Samet, are you going to close the Peterson hole in this patient? Because Gianfranco
No,
says that
no,
it is a
actually,
compulsory.
Yes, it is controversial. Actually, yes, I have. I read some reviews and some meta-analysis favors closing the mesenteric defects, but during the closure, I think there are a lot of complications, intraoperative complications, and they are not reporting. So I am not closing, and Dr. Balta's preference. I asked him, and he will not close it.
Sorry about this. This is the no. There are things that we have not to discuss. This is a course. We have to give a take-home message based on the evidence, the literature for the safety of the procedure. When you have an anticolic, antigastric route in Robotic gastric bypass, there are 11 randomized control trials that demonstrated that the closure of the mesentery defect minimize systematically in all trials the incidence of internal hernia. Considering that the internal hernia is an emergency and the mortality for internal hernia is not zero. So I think that in a course, the message is the evidence of the literature advise that the closure of the mesentery defect is mandatory to prevent the internal hernia. And the internal hernia can occur 1 month after surgery, as well 10 years after surgery. So the mesentery defect should be closed using non-absorbable suture. Sorry about this.
Gianfranco, you are right. The most meta-analysis shows that the closing mesenteric defect reduced small bowel herniation. But we know that when we close the mesenteric defect, hiatal internal herniation rate is about 3%. But if we not close, it's the 5 or 5.6% like that. The closing the mesentery defect has some disadvantages because of during the closing we cause the small bowel obstruction and
a long discussion since 20 years,
Yes.
but the evidence demonstrated that you need a training for the closure of the mesenteric defect. Keep your time, keep calm. The procedure is not finished. It's a psychological view of the problem. When the surgeon complete the procedure, before to close the defect, consider the procedure closed, and then quickly complete the procedure. Take your time. because the closure of the defect is mandatory. In Italy, where the medical litigation, in this case, if you have an internal hernia and you haven't closed the defect, you don't find any judge that don't condemn you. The problem is evidence of the literature. What we can do, no discussion. We have to learn, we have to train to close safely the mesenteric defect. You are right. Me too. Sometimes I have hematoma when I close, but to keep your calm, you put a sponge, wait 5 minutes, and go on. But to leave opening the defect, that you have the risk demonstrated in randomized prospective control trial to have a major incidence of internal hernia with mortality. So in my practice, in my country, if you have a litigation for an internal hernia, there are no option. There is no good lawyer that can help you. So it's like the trocar. If you have a trocar not closed and you have an hernia of the trocar, you have occlusion, you have problems with and you in your report you had not signed that you close with no non-absorbable suture, the trocar site is the same. I think that the advance of this course is that there are some things that we don't need to discuss anymore. And one of these things, in my opinion, is the closure of mesenteric defect. Please don't consider an option, but please consider as part of the procedure. Sorry about this.
I totally agree for RMY with you, Gianfranco. And initially, evidence was saying that closing and not closing is the same as compared to rate of internal hernia. But there are many studies and many 1 or 2 prospective studies saying that if you don't close it, and definitely your patient will suffer from internal herniation, which might end up in mortality as well. The other people says that even if you close it, when the patient lost weight on the closure material, is going to make life difficult for the internal herniation as well. So that's why some people suggest that you have to use absorbable material, which is not vicryl. It should be something like PDS. It should be absorbed longer than vicryl, but it shouldn't be Prolane. Some people used to use Prolane suture, which might cause the terrible problem when the internal herniation is there after weight loss.
I use Prolene. Sorry, I use Prolene 20 barbed V-lock 50 centimeter, because I think that the barbed suture allowed to make a safe, because you can hold the suture and you can you can have a safe suture of both the Peterson and the mesenteric defect using the 15 centimeter V-lock 30 Prolene, because the non-absorbable suture help in this case. Before that, we have the barbed suture. I was to use PDS sometimes, single stitch, but when we have the barbed suture, I prefer definitely the barbed suture.
Barbed PDS, V-lock PDS with the, we can see that barbed suture. So that's why I use PDS instead of Prolene.
I prefer Prolene because I feel
As
more
long as barbed
comfortable
sutures, yeah.
with the non-absorbable suture. But the main topic is the closure.
Okay.
Barbed, non-barbed, absorbable, non-absorbable. The main topic is close the mesentery defect.
Okay, the message has been taken, and we can see that the procedure is completed. Samet, sendeyiz. Procedure tamamlandı herhalde.
First of all, we request we were making the surgery, we were performing the surgery under hypotension. And first of all, we requested anesthesia to make the blood pressure normal, because if there is any
Check
bleeding
the blood,
normal
yeah.
pressure, we want to see. And now we are making the methylene blue test.
Yep.
Methylene blue test. Yes, we're checking the anastomosis. We give 50. Yes,
Slowly,
50.
slowly, slowly. It looks perfect. So then release the methylene blue and look at the enteroanthrostomy. What I do is after this test, a lot of methylene blue will be inside. Rather than absorbing the methylene blue, I will leave it and go down and check the enteroanthrostomy. There's going to be some methylene blue inside the bowel anyway. Yeah, that looks perfect. Are you going to bury the staple line in here or no? No.
No, only he will put the clips.
Okay, perfect. Okay, when you put the clip, are you going to put, I mean, one suture on here, we can see some tear on the serosa. I don't know whether it's too big or under the clip. There's a tear on the serosa.
Huh? No, we saw that. We decided to suture that serosal defect after methylene blue test. We will use sutures for the serosal defect on jejunum.
Okay, perfect. So after clipping this line, can you just show us the enteroanthrostomy again and then show us all team? We would like to thank you and we would like to show our appreciation and then we will leave you alone. To close
Okay,
up the
thank you.
patient.
Bütün takımı, bütün ekibi bir gösterelim. Evet.
Can we have the team on the big screen now?
Bağırsak şeyde var. Bağırsak.
Varsa alırsınız siz. Sonra biz sizi bir görelim abi. Tek tek isimlerinizi alalım.
Tamam.
Celal de geldi
Nerede
herhalde
kamera?
oraya.
Celal de
Ver
burada.
kamerayı.
Tamam.
Ver kamerayı. Celal de gelsin. Şöyle bir fotoğraf alalım. Elektronik ekibi bir fotoğraf alır mısınız ekrandan? Bekleyin arkadaşlar.
Biraz şöyle öne gelsin. Ev sahibi.
Biraz öne gel.
Thank Celal for arranging the patient.
Okay, that was a great piece of example of Romaine gastric bypass, especially on a revision cases. I would like to thank you all, but especially Celal for organizing that cases and also arranging the procedure for this symposium. And I would like to thank Ahmet Ziya Balta. Professor Balta has shown a piece of good piece of example for the revisional surgery, and Samet. Professor Samet Yardımcı, I would like to thank you as well for your explanation and for your guidance during all that procedure. And also the assistant, I missed your name, just tell your name again.
Evet.
Yeah, to Mert for the great control of the camera and the assistant during the procedure. And I'd like to thank the nurses and the supporting team of the theater. And we would like to show our appreciation by clapping your success in both cases. Thank you. And we have to leave, and you can close your cases, and we will carry on with the talk of Gianfranco Seleccia on obesity and breast cancer. Biliyoruz arkadaşlar, kimse gitmesin, 10 dakika sonra Gianfranco'nun konuşmasını dinleyip sonra bitireceğiz. Zaten 2 saat erken bitirmiş oluyoruz. Çok isabetli oldu.
Yok.
Yok bayağı iyiydi.
Bir tane de şey lazım bize. Ne o? Pasta kapatıcı lazım. Değil. Tekrar şöyle bakalım. Bunu da şöyle açalım. Kapatmaya gerek var mı? Ben kapatmıyorum.
Yok yani.
Kapatmayacağız zaten. Bir tampon ver.
Abi bak bir şey diyeceğim. Ben demin onu söyledim de defek kapatırken insanlar başına gelenleri yazmıyor ya ama hani defek kapatırken nasıl kanamalar, nasıl mezodan bilmem neler, hani defek kapama işi Hani evet, evet.
Geri gel.
Buyurun.
Şöyle göreyim ben.
Ama bunu bana bırakma bak. Bütün karın indi. Dur abi bir saniye.
Geri gel. 45 Prof. Geri gel.
Ay.
Nereden getirdin? Geri gel.
Orada da kamera varmış zaten. Bize niye orayı göstermedi? Biz de onlara bak görseydik. Ha. Versene bir. Elsa'nın şeyinde de yayınlandı bu. Bir tane çamaşır evet. Evet.
Hocam bunu biliyorsunuz.
Evet. Bu şeyin içine gel. Ver bakayım. Tamam.
So it's my great honor to introduce Gianfranco Slecce again. Gianfranco is a head of the department in Sapienza University of Rome, and he's also running the doctorate program in surgical oncology. And he's a well-known surgeon not only in Italy, also in Europe and United States as well. What I found yesterday is they were actually classmates with David Lomanto, but they went to honeymoon together to Australia. And they married together. They went to honeymoon to Australia, flying business class. So next time I will try to do my best to get you here with business class flight. And always I'm honored to have him on my side. He's a great scientist and very good surgeon. You can see, you can understand from all that questions that he's asking. He knows the steps and he follows the rules. He never comes out of the rules, but sometimes you need to leave the rules alone and go ahead straightforward. But as a scientist, he always follows the rules. So that's why you can rely on any paper comes from his department or under his name. It's my pleasure to introduce him. And then I'll leave the stand to him. Please, Gianfranco. He's going to talk on colon cancer and obesity, which we are doing some research on it together.
Thank you very much for the invitation. Congratulations to Medtronic for a high level of the course. Congratulations to everybody. I've seen this morning a very nice procedure. That's very important for the surgeon, but the cultural background around the obesity and the effect of the metabolic procedure, I think, should be part of the luggage of every modern bariatric surgeon. I have a great conflict of interest because this is one of my favorite topic of research at the moment. And during the last few years, I'm focusing on this topic. I will try to share with you results of my research and what are the evidence from the literature. I have no disclosure except the disclosure that I said before. There should be by agenda, and we'll try to clarify what does mean obesity-associated cancer, the epidemiology of this, the mechanism of cancer development in obese population, the effect of metabolic surgery on the cancer risk, the protective effect of the bariatric procedure, and the clinical implication of the current evidence from the literature. My friend, these are the figures. World Health Organization in 2002 said that 89,000 million people suffering with obesity, and that the colorectal cancer risk in those populations is have a range between 25 and 54%. So every 1 point of increase of BMI, there is the risk of increase of the 2% of the risk of colon cancer development. Remember these figures because the numbers and the figures are very important. We have a 9% increased risk of rectal cancer in men for every 5-point rise in BMI. So the epidemiology was said that the colon cancer and the rectal cancer in obese population are a different impact, and that the gender has a different impact. From the other side, the colorectal cancer is the third most common cancer in the world, and the second most common causes of cancer-related death in the world. This is a paper published a few weeks ago. It's a very important paper published on epidemiological journal, not a surgical journal. and looks for the first time to this data, the global distribution of colorectal cancer related to obesity. And what are the results of this very interesting study? That the death due to colorectal cancer in IBMI in 1919 were 41,000 and more, and 20 years later, we have plus 140%. And if you see the color of deaths, you see that there is a parallel distribution of the prevalence on obesity and the prevalence of colorectal cancer. Those data are very important for stakeholders that have to organize the management of obesity and the screening of colorectal surgery, considering that obesity has an epidemiological impact without discussion. This is a paper published by NICE in International Journal of Obesity 10 days ago. Came from the UK Biobank, and looking for a very large cohort of adult patients, more than 45,000 people, with a follow-up of 12.5 years, very long follow-up. They said that they demonstrated that a BMI more than 30 account for an increased risk of colorectal cancer of the 26%. But what's very interesting, it's the weight-to-hip ratio, 45%, the waist circumference height, 41%. And the conclusion of this interesting paper is that if we measure the waist circumference, we can predict the risk of the colon cancer in obese population with zero cost. And this paper published on the 26th of February, 8 weeks ago, demonstrated that the obesity overlap the smoking. It is the most important preventable disease to reduce the risk of colorectal cancer. And underline that today we can see that approximately 1/3 of colorectal cancer-related death occur in patients with obesity. Please think about these figures. Inform your patient. We have to stop to discuss about the stitch, taper. We have a big issue, which is the cancer. And we talk about the effect on diabetes. The effect of diabetes, we have big data that support this. But in my opinion, we are still under the minimum of awareness about the obesity and colorectal cancer. Obesity and cancer. What are the advocated mediators of this strong evidence? First of all, the chronic low-grade inflammatory state, which is proper of the obesity condition. There are millions of papers that demonstrate the low chronic inflammatory state in obese population. The insulin resistance, specifically the increase of the IGF-1 protein, the microbiota, And I don't know what other mechanism we can add for this link. I think that the microbiota is one of the most important, interesting things. This paper published in Obesity Review 3 weeks ago demonstrated that the impact of microbiota on the risk development of colorectal cancer in obese population is related to on gut dysbiosis, on the metabolic disorders related to the dysbiosis, reduction of the adiponectin, the increase of leptin, and the inflammatory state, as demonstrated before. So there is a perfect storm around the obesity condition, starting from the gut dysbiosis, the change of the gut microbiota profile in obese population that stimulate the cascade of metabolic disorders and inflammatory. Altogether, this is one of the advocated mechanisms today proven as related to colorectal cancer development in obese population. So obesity is associated to colorectal cancer as an independent factor. But if you see what happened in non-obese and obese, and we go deeply on the microbiota-derived metabolites that act on tumor cell, there are the short-chain fatty acid lipopolysaccharide, the different low polysaccharide, the glycophospholipids, and the bile acid. And say there are mediators that are completely different in obese and non-obese population and act as mediator. And today we can measure this modification and this change. So the change, what happened when an obese patient received the metabolic surgery, and what are the link? What happened after metabolic surgery? The advocated mechanism that affect the risk of colorectal cancer are the change in bile acid pool after metabolic surgery, the increase of GLP-1, the mucosal expression of COX-1, the weight loss, and again the microbiota change after the metabolic surgery. So we have the clear mechanism that can be balanced in the history of colon cancer development impact after metabolic surgery. This is a retrospective study, but I love it because I think this is one of the most important paper that demonstrated with a follow-up of 5 years was published in Annals of Surgery from the group of Alfonso Turquati in Chicago, and demonstrated that bariatric surgery was associated with a decrease of colorectal, liver, lung, ovarian, uterine, and any other cancer within 5 years post-operatory compared to no surgery cohort. And say they looked to two big cohort, matched. One cohort underwent bariatric surgery. The other cohort received medical treatment, diets, and so on. And they observed a statistical significant reduction in the metabolic surgery cohort. And looking specifically for the procedure, there is no statistical difference comparing sleeve gastrectomy and Roux-en-Y, because the second question is if the metabolic surgery impact on colorectal cancer risk, there are among the procedure that best performed in this. There is no statistical procedure. This is a systematic review that follow this and looking for a very large population of bariatric surgery group and control. There are 3 prospective study, includes the SOS study, 29 retrospective study registry based. They put all together all the bariatric procedure, and as you can see in the Forex plot, the metabolic surgery reduced the risk of 0.59 its odds ratio in bariatric population. This is the last paper involving 12 million. It's correct. 12 million of cases that demonstrate on a very large study a reduction of colorectal cancer risk up 54% with difference in gender. Sleeve and Robotic gastric bypass are similar and don't have any effect on the risk of development. So I think that there are very strong data, and we have several data to discuss with our patients, to discuss in the multidisciplinary team that manage the patients, and to change our mind, considering that our patients have not only the risk of develop diabetes, but have also the risk to develop a colorectal cancer and other 11 obesity-related cancer. We discuss with our patients a lot, say that you have a risk to develop diabetes, cardiovascular risk, and other comorbidity related. And we'll be honest, we don't spend enough time to explain to the patient that his risk include also the development of colorectal cancer or breast cancer or other cancer. So that 2 years ago was published this systematic review and meta-analysis based on registry data. The question was, what's the impact of bariatric surgery on the incidence on colorectal cancer, published in Obesity Surgery, so in a surgical journal with a follow-up of 5 years. And this is one of the last data, and say that the bariatric cohort incidence was 0.6% with a reduction of cancer risk development of 40%. And the sleeve again has the same effect of Roux-en-Y gastric bypass. This paper published on cancer consider a time interval between 2020 and 2023, and with a follow-up between 3 and 20 years. And this is one of the few papers that consider separately the risk of colon cancer and the rectal cancer, and analyze a subgroup considering the different procedure. And this is the first paper that said we don't have any difference on the impact on colon and rectal cancer. The risk ratio is the same. And again, there is no statistical significant difference comparing sleeve and the Roux-en-Y gastric bypass. Is the protective effect of metabolic bariatric surgery still controversial? Why this question? Because a few years ago, my lecture will be 50 minutes, not 2 hours, were published in the literature some papers coming from the north, Finlandia, Sweden, that analyzing data consider the metabolic surgery as concerned the rectal cancer, a worsening condition, analyzing modification of mucosal receptor, the weekly transit of the food, and they consider a high risk of developing rectal and colorectal cancer, they suggest in their population. After that, a long list of papers that I showed you before demonstrated just the contrary, but this is still a controversial issue. In my view, is not a controversial issue. However, to be honest, 3 days ago was published this paper analyzing 2 cases. Yes, 2 cases. Number 2 cases, 2 patients submitted to Roux-en-Y gastric bypass, were collected the faces for 2 years, and the authors, on the basis of 2 cases, suggested that the tyramine derived from the diet and the bacterial metabolic of tyrosine facilitated tumorigenesis and colorectal development after Roux-en-Y gastric bypass. I don't know how microbiome can publish this paper based on 2 cases with a follow-up of 2 years. But honestly, I reported this last-minute paper that just say that supported that the effect is controversial. What about my research in Italy? In Italy, we don't, before that we published this paper, we don't have any data as concerned the incidence of colorectal cancer in Italy in patients after bariatric surgery. And we wanted to analyze, comparing the 2 most widespread laparoscopic procedures, sleeve gastrectomy and Roux-en-Y, what happened in our country. This study was published in International Journal of Obesity 3 years ago and was endorsed by the Italian Society of Endoscopic Surgery, was a national survey. We send the questionnaire to the 53 bariatric center of excellence of my country, and we get the answer from 34, the 63%, and we ask to report the case of colorectal cancer between 2010 and 2015, a 5 years period that have a minimum follow-up of 5 years in 2020. So this is the distribution of the center covering all my country, the north, the center, the south, and the island. And we collect 20,571 cases of sleeve gastrectomy, primary sleeve gastrectomy, and the primary gastric bypass, all completed laparoscopically. And the difference of the figures, the mean age of the 2 groups of sleeve and Roux-en-Y was similar. And also similar was the BMI of the patients was around 44 in both groups. And the percentage of female, of course, was around 70%, as occurred in any series around the world of our series. We collected 22 colorectal cancer diagnosed and treated in those periods. The majority were male with an incidence of 0.10%. Interesting is the mean age of the diagnosis of the colorectal cancer was 53 years, And the mean interval since the index procedure and the diagnosis of colorectal cancer was around 4.3 plus minus 2.3 years within 5 years. And say this is, in our experience, the interval risk of developing. Interesting is the mean age. As you can see here, the majority of the cases were collected between the 4 and the 6 year after the index procedure. If you look to this data, it's very interesting. Sorry. If you look to this data, you see that the male, we have 7 cases after sleeve gastrectomy and 6 cases after Roux-en-Y gastric bypass without any significant difference. In female, we have 5 cases and 4 cases, no statistical significant. And the mean BMI at the diagnosis of cancer was around 30. The mean BMI at the index operation was 44, at diagnosis of cancer was 30. If you look to this data, you say that, again, the location of the cancer was after sleeve gastrectomy, right colon, transverse colon, left colon, rectum in 2 cases. After gastric bypass, right colon, transverse colon, left colon, 1 rectum. If you look this data, it seems that the major incidence was in the right colon. It was in the colon on the rectum. And if you consider the standardized incidence ratio, the SEER, it was absolutely similar after sleeve gastrectomy and Roux-en-Y gastric bypass in female and in male. The conclusion of this paper was that there is a very low colorectal incidence after bariatric surgery at the 10-year, which is absolutely similar with the incidence in the same range, same age in our population from the epidemiological data in Italy. And there is no difference between sleeve gastrectomy and Roux-en-Y gastric bypass, suggesting that anyway, that's sure. The bariatric surgery is not a trigger for neoplasm development, at least. This paper has a great impact in my country and started the discussion, but the diagnosis of these patients, they had before polyps, they attend the screening. In Italy, there is mandatory after 50 years old to have a screening for stool and then colonoscopy. They attended the screening test. When they received the procedure, they had just polyp or cancer, small cancer, and so on. As you know, it's not mandatory in the guidelines to ask a colonoscopy to all patients. However, if we consider the treatment they receive and the stage of the disease, and they treat more than 80% of the patients are survival at the last follow-up, and there was 0 case of stage 4 and in both groups. This means that the follow-up, the strict follow-up of the bariatric patients may help to have an early diagnosis of the colorectal cancer and to guarantee an intent to cure procedure in those cases. If you see, the majority of cases that we diagnosed were stage 1 and stage 2. So it's very difficult to draw a conclusion on this topic because several studies are running now. But what we can say to our patients and to our colleagues in the multidisciplinary team is that the metabolic surgery impacts favorably on the colorectal cancer risk, and the most diffuse procedure have the similar effect, the similar protective effect. The awareness of the obesity as condition, as independent condition per se, as a condition favoring development of the colon cancer, I think it's something that we have to discuss and we have to implement, and we have to put more of this topic in our Congress. I don't know if the future guidelines should incorporate the colonoscopy in the high-risk patients with familiarity of colorectal cancer, previous surgery, gene modification, Lynch syndrome, and so on. I don't know. There are no data that support this. Anyway, I'm sure that all the patients that enter in a program for a bariatric surgery should be encouraged to participate to the screening program for the colorectal cancer. And the patient have to know that the population of obese is at a high risk for development of colorectal cancer, and they must attend the screening program. What should be the alert for bariatric patients at considering the high risk for colorectal cancer? The age, the familiarity, the genetic syndrome, and the data can be the gender male. Anyway, one message is clear. The obesity management is crucial to reduce the risk of colorectal cancer risk today, and we have to consider that mission as one of the topic in our multidisciplinary team, because we have the responsibility to face the obese population more than other specialists. And the awareness on this topic, I think, is mandatory in 2025. If 40 people today go home without any doubt about this topic and consider obesity, this is the main factor involved in colorectal risk, and the management of the weight loss is mandatory to reduce the risk, and metabolic surgery protect against the risk, and the awareness of the link between obesity and colorectal cancer should be introduced in our clinical practice, I will be very happy, and thank you very much for your attention.
Thank you very much, Professor. You open our mind about this topic. It is discuss about this. Thank you very much. Have you any question with the audience? The final.
No, there's some questions.
Yeah.
You go.
Thank you for your excellent presentation. I'm question is related about the theoretical concern. Is there any colorectal cancer risk reduction if the patient lose same weight lose by diet, and if the patient lose weight loss by metabolic surgery? Is there any differences between two groups? We have data.
There are no data.
I think the follow-up of this patients should be more than 10 years. You know, the colorectal cancer developed in the 10 years from the cell to the cancer. The short follow-up may be concerned about it. If you plan any future future study or future research, we should follow up like this patient more than 10 years. Because it's the short follow-up should be open for discussing.
I agree with you, but we'll be honest. Share your hand. How many of you talking with your patients, your bariatric patients, spend 5 minutes to discuss the topic of obesity and cancer? Thank you for coming your home and thinking about my words. And next time that I come here on this topic, we will present data on another cancer, because another topic is the breast cancer. There are dramatic figures. In my practice, what I do, I don't operate in female that don't attend to the screening test in Italy. If they don't have the screening test 1 year before, I ask mammography and ultrasound in old age. And all the patients that I operate, I ask the stool test for the colorectal cancer. If you introduce the stool test, the cost is nothing. And no one of the patients, and I ask them to attend the screening for the breast cancer, were not happy to receive these suggestions.
Gianfranco, thank you for
Thank you to you.
No, hang on. Thank you for the presentation. Don't go anywhere. I lost something. My question is the incidence rate of patient with the colon cancer in your study is too low. We cannot actually conclude anything about the bariatric surgery, saying that bariatric surgery is actually preventing colorectal cancer, because maybe that patients that you had in your group had the tumor polyp cancer sequence. You know, the lesion was initially too small, it's the microscopic level in situ cancer, but you didn't pick it up. And then after bariatric surgery, they had the cancer because the cancer was already there. So the rest of them didn't have the cancer. But my question is, who is the patient under risk, which or in whom we need to do surveillance like colonoscopy, like we are doing endoscopy for upper GI patient in every bariatric surgeries? Whether we need to do colonoscopy in every bariatric patient as well?
There is no data support to the colonoscopy as routine tool, but anyway, I think that we can, if you want to identify, I think that if you want to identify a subgroup at high risk, consider male, age, considering that the peak of age of the colorectal cancer is between 60 65 years old, when male over 60, familiarity of gastrointestinal cancer, genetic syndrome, patients that have syndrome like Lynch, other rare, polyposis, APC, patients that had the previous polypectomy. So in those cases, I think that today there are strong data to suggest a colonoscopy before the bariatric surgery to the patients. But the problem is, if you demonstrated as scientists that in your country, in the Middle East, the incidence of colon cancer after the introduction of metabolic surgery decreased compared with the era of pre-minimal invasive surgery, bariatric surgery, you have in the pocket the card to say, my friend, we are not operating people to go to the beach with the 38 sides, but we are operating people to reduce diabetes, to control diabetes, and to reduce the risk of cancer, which is something different. But to do this, you need multidisciplinary team, awareness, cultural approach to the problem, and thinking about all the conditions of obesity patient.
If there is no other question, yeah, of course.
Yeah, I think this study is working on gastric cancer because before bariatric surgery, most of the surgeon doing endoscopy for the surgeon gastric cancer. If you compare who did metabolic surgery or the not metabolic surgery for the gastric cancer, maybe we reached the more objective results at the end of the study. You think about the gastric cancer.
Usually, I don't like to give opinion. I like to give data.
Yeah.
And to give results. And I think that today, the bariatric community and the colorectal community should make a great effort to work together.
Yes.
To considering the subpopulation of obesity and cancer. If you want, you can compare, for example, for the pancreatic disease, before the IPMN evidence that was a condition, the criteria for the, well, because was considered a malignancy, there was a confusion, but thanks to the effort of all the people around the pancreas, radiologists, the surgeons, so on, the oncologists, they set up the. I think that today is the time when colorectal community and the obesity community should work together because they can make a good goal more than very expensive campaign of prevention of colorectal cancer to reduce the colorectal related mortality.
Of course.
Let me give one data from Turkish study, which we just sent to International Journal of Colorectal Disease, which is accepted, run by my wife and the PhD students. We look for the 130 patients with obesity and metastatic naive colorectal cancer. We found the relation between the visceral fat and adiposity of the patient and the BMI of the patient and the rate of the colorectal metastasis. Of course, the number is too small, but they are also looking for some special receptor expression level on that patient and also identifying the specific HLA location, whether we can find out in the obese patient. So we are also planning to go ahead and do the same kind of research with the Italian colleagues run or directed by Gianfranco in the future. Thank you, Gianfranco, for this fantastic speech and open-minded look to colorectal disease and the colorectal cancer and the obesity. We always love your talk and we would like to have you back again here for the Bariatric and Metabolic Surgery Congress, which will be held on 1st of October in Turkey. And we can discuss more on that time. And I also would like to thank all speakers and all participants for joining us for today as well. That was 2 examples of the successful surgeries we were able to see. And now it's time to close. And before closure, I would like to thank Medtronic, especially Feride Özlem Çağıran for organizing all this symposium. Because without her help, it wasn't going to be quite easy to do this kind of activities because of the economic situation in Turkey. And also I'd like to thank the other team of Medtronic, Umut, Sarah, and many others that I can't remember the names at the moment. And I would like to thank the General Manager, Volkan Ünlü, for supporting us. And also, last but not least, I would like to thank Solo Event for making this event with the help of Zoom event, and especially Murat Ceyhan for coming and staying with us all the time. He's the manager of the company, but he stayed with us and he made everything possible and reachable for us. I would like to thank you all, and I want you to clap them, applause them, and thank you. Now, if you don't mind, Medtronic wants us to have another picture inside this time before we go. Thank you. Thank you very much.
Thank you very much.
I invest too much funds. You know, sometimes I know our colleague, my colleague too, usually they consider that the point, the crucial point to inform the patients is the diabetes. I consider a limitation to inform the patient only on the diabetes and so on, because I think that the patients are at the same time, you know, risky for complication, cardiovascular complication and diabetes, but at least have the same risk of colorectal cancer. I think there is a large possibility to study, to cooperate, to make, to have a new data. I don't know, maybe for next year we will have more data about this. Now we are focused more on the breast cancer. Because this is in Italy, there is a national network of the breast cancer unit. So because in this case, you know, it's not difficult. They have just a tower.
Hocam liderlik de çeker misin?